So we've got Dr. Emily Ryan from the Department of Health, who is going to talk us through the new draft policy on advanced practice, and we have Dr. Mary Doolan from the Nursing and Midwifery Board of Ireland, and we have a visiting professor, Professor Andrew Cashin from Australia, who's written quite extensively on advanced practice. And the purpose of today, and we also have our Dean and Head of School, Professor Feely. The purpose of today's discussion was really to try and highlight some of the areas of concern and some of the areas of, to explore, I suppose, some of the new developments that are happening in this space. I think we're very fortunate that we have a very progressive and proactive Department of Health, or in terms of the Chief Nursing and the Deputy Nursing. And I think for a small country, I think there's a lot to be said for working collaboratively to try and get the best programme possible. So hence we've opened up the webinar, and we are going to record it so that anybody who wants to kind of revisit it and pick brains is quite welcome to do so. And we're going to start with Dr. Anne-Marie Ryan.
Hello, good afternoon everybody. As Mary has said, that I'm currently working in the Chief Nurse's Office of the Department of Health. I'm one of the Deputy Chief Nurses who has been taking the lead on an initiative to look at graduate specialists and advanced nursing practice. And just to put this in context, I think in Ireland we're very lucky in that our Chief Nurse's Office is located within the Department of Health at a particularly high level, in that it is it's at Assistant Secretary level within the Department of Health, which means that it's at the senior policy decision-making table, the same as the Chief Medical Officer. So as a consequence, I suppose that the policies have that context in that they can then move into that next implementation space. And what really the policies we're trying to do is to reflect some of the current challenges within the health services in Ireland, and that these were identified and captured in two documents. One was the Better Health Improving Healthcare, a strategic briefing document that was prepared for the Department of Health when we got a new government 18 months ago, and then there was the Programme for Partnership Government. And within this, what we suggested in the CNO wrote her strategy is that that nursing, in fact, could make a contribution. What we wanted to do was look first off at the values that nurses and midwives brought to the table. And within that, last year we identified compassion, care and commitment from discussion with over 1,000 nurses within the country. And we identified the behaviours associated with that. What we wanted to try to do with these then values was to try to maximise the outcome and the outcomes of our practice, and at the same time there was a study set up about a framework for safe nursing staffing and skill mix, and that's been led by my colleague Dr. Philippa Wither-O'Ryan. Philippa's work is based on the work of Dr. Linda Aiken and the ORN forecast. And what we're doing is that we're using now an evidence base to work out how we should be staffing our wards. And it's not who shouts the loudest, but she has identified a large number she has identified the factors that should be included, including missed care opportunities, safety queues and that. And the first phase of that would be published in the next month or so. We're now going on to phase 2 of it, and we're also going on to look at how staffing should be in the EDs. The main thing we wanted to look at, though, was to stabilise the resource, and what were the things we could do at a policy level to be able to do this, and how could we deploy and appropriately maximise the scope of practice of nursing and midwifery. So within this, there are two policies that I'm going to give you a very quick overview on at the moment, but what we also then want to do is we want to measure this impact, and there's another paper then in preparation at the moment about looking at the KPIs and what we can do to be able to measure this. So in essence, to go back to the first paper that I mentioned before about better health improving healthcare, there were three massive challenges that we were really dealing with. We're looking at sort of how to get access. Can we look at primary care? Can we look at and what can we do in relation to this? What are the population health needs? How are we responding to them? And the HSE, for our international people who are on the thing, is our health service executive, and that's how we manage the health services. They have 5 integrated care programs that I'm going to talk about in a moment. And really what we want to do is see, can we change the delivery of care based on 2 principles. One, can we introduce choice for the population to access the healthcare? And then can we maximise the contribution of nursing as a response and function of the service needs and the current challenges we are looking at? So in relation to that, our government identified 2 aspects that we could develop, which we did. One is on public health nursing, and then the other was about the working practices, particularly about specialists and advanced practitioners. And what we were trying to achieve, well, the problems that we have in our health service at the moment, no more than anybody else's, are hospital avoidance. How can we avoid our patients having to come into hospital unnecessarily? What are the issues associated with patient flow and patients both getting in and coming out of the hospitals? Can we look at issues associated with early discharge, access and choice of health services? And we have a big problem currently with waiting lists, and some of this is our access and choice of health services are to do with our trolleys and what we have on things. So my colleague Susan Kent developed a paper in relation to community nursing, and we have particular problems, I suppose, within the community nursing services at the moment in Ireland. What we did was she developed a policy based on evidence, and she then supplemented it then by doing her own piece of work to see what's actually happening in practice. We have a large selection of nurses and midwives who are working across our community structures, but they all have very different governance structures, so there's no one kind of reporting relationship. So nursing is very diverse within the system. So for a patient, it's very confusing for them. They don't know how to be able to access the services or where they can get it or what would be the best thing to do. So navigating the system has become a difficulty for a lot of us, and for our patients and for our families, in fact. So one of the big impetuses from the HSE is about looking about integration. How can we best integrate community and our acute services? And at the moment, it says that they're sort of working kind of within silos and that, but what we were suggesting that the mainly ANPs and CNSs, ANPs, the advanced nurse practitioners, and CNSs, the clinical nurse specialists, these we want to be able to work, that they can work from both across the acute services and the community services, because currently they are working in either one or the other. We want to be able to see, can we provide acute services in the community and not replicate services that are currently happening in the acute services, but there are some services that are happening in the acute services that could more easily be offered in the community. We want to then to look at what our public health nursing service and see what are the pockets of integration to be able to do this. Because what she found was that there was a lot of duplication of services, there's been fragmentation of services. There was a large report that was done here in UCD last year that showed potential miscare in the community. We've got different governing structures I've mentioned before, and in relation to leadership, it's very difficult then to be a leader when everything is so disparate in its own way. We have some wonderful leaders, but it's trying to sort of bring it all together into the one space, to look at service need, to look at some of the discipline-specific competencies that we need to look at some of the regulatory standards, the values and the principles of where we want to work, because what we want to do is to work in an integrated way as opposed to working out in silos. I suppose the current services that we have in Ireland, when we're looking at our national picture, is we have very much a reactive service in the community as opposed to a proactive service. So we want to invert that, and then we want to be able to see what we can do with the clinical nurse specialists and advanced nurse practitioners, and also community nursing services themselves, and just re-look at them. Because internationally, a lot of countries have actually dealt with this. We all know about this, the population health pyramid, that most of our services are associated with the top 20%, and there's something that we can do within the nursing services. But one of our problems in Ireland, well, not problems, but our challenges, is the eligibility criteria that we're currently using. So that's one of the policy issues that Susan and I are going to have to look at. So if we were going to have some success about this, what would we look? We would have a population need by developing a nursing and midwifery workforce that has the competence to collaboratively integrate, and particularly we want to look at an eclectic model of care with the nursing and midwifery being the first point of contact. And this is, at the moment, we have services that are very good at early years, and we have some quite good services in around older years. Where we have a lacuna is actually in the working years, so the working well and having a nursing service in the community that can service those. So what we were looking then is to try to work towards more an interdisciplinary model versus a multidisciplinary model. And this particular model is kind of the model that Susan came up with, about having nursing and midwifery as the first response. And I'm going to take you to the next slide, and I'll come back to this other slide then in a moment. What we're talking about is having primary care centres. We currently have 97 of them in the country, but we could have these then that there'd be nurse-led. We have services in the community where the nurses can actually work out where is the most appropriate place for the patient to be, whether it's to go to the GP, whether it's to go to the hospital, or whether it's to stay in their care home, or we can provide some of the services then in the primary care centres around the country at the moment. Our national ambulance service is a new policy, and we will be able to utilise them for, at the moment, the only place that the National Ambulance Service can refer somebody is into one of our EDs. So they are now going to move, that they can move to a GP, but also where they will said they will bring it then to the primary care centre. We also have some community health nursing and midwifery intervention teams. At the moment, these are kind of privately organised services, and we're suggesting as we would integrate them then into our primary care team. And in particular, an example of it would be that even in a nursing home, if a patient was deteriorating, instead of having to ring an ambulance and bring them into the ED, they could actually contact the primary care centre, and nurse could go out and make an assessment on the patient. An advanced nurse practitioner could put them up on any IV antibiotics, could refer them in for an X-ray, all of those types of things that might need to be done within that service. But to come back to Susan's other model then in relation to that, we're talking then about intermediary care and anticipatory care. And this is where I'm going back to that 80% of that triangle that I showed you a second ago. In anticipatory care, we could look at some things, because into our EDs, falls are the first presentation type that we get into the EDs, and the second then are respiratory conditions. So if we look at this in particularly about respiratory and chronic disease management of anticipatory care, we might be able to prevent the patient having to come in every 5 and 6 weeks if we get them sort of at 2 weeks and 4 weeks, and we make interventions at a more appropriate time. Continuing complex care in the community is something that's very disparate at the moment. You can get, it very much depends on the geographical area. We want to be able to streamline some of that, and we want to keep something that we have that's really good, that other countries want and don't have, and that is our protection, promotion and prevention activities. And there is new legislation coming in into protection of the older person, so this actually is going to create a large body of work that we're currently not addressing at the moment, while we're addressing it in a little bit disparate sort of way, but there'll be new challenges associated with the new legislation. So coming back to what she's hoping is, she's hoping for a new model of how we're actually going to do governance, and we have a paper that we would like people to go onto the Department of Health's website, onto the CNO's office, and we have something there we would like you to contribute, particularly into the governance models, because Susan has 4 different types of governance models that she would like to. So to get on to my particular one about advanced practice, I want to be able to support Susan's model then in relation to advanced practice. Currently, we've had a model for advanced, we've had a career pathway for advanced practitioners since 2001. But we have, with 65,000 nurses on the register, 36,000 of them working within our public health service at the moment, we only actually have about 200 advanced nurse practitioners that are currently in post working. And of that, we have 78 of these, or actually gone up now to 82, are working in our ED departments. And we have 53 specialties. So we've created this micro-specialisation of nursing, and so at the moment we don't have a critical mass to be able to show that we make a critical difference. We've wonderful nurses who are doing individual work, but what we want to be able to do now is to look and see, can we create a critical mass that can come back to the problems that I mentioned to you earlier in relation to this. So when we looked at some of the things about the OECD, and we know now as well that Australia are looking to get 2% of the population as an advanced practitioner, we're saying, well, we're going to try and do the same by 2021, going from a low of 0.2%. So that will give us 700 by 2021. Okay. Sorry, I have the wrong slide up for that. I didn't realise. I beg your pardon. So that's that slide that shows the different things. Okay. Many people here who are around on this webinar, I'm sure, know the benefits of advanced practitioners, but and like that, I say, our problem is that we don't have a critical mass of them working in particular specialties in that. But in relation to chest pain, we have this particular, the patient experience times were reduced from 17.5 hours down to just below 8 hours. But more importantly, 76% of the patients didn't have cardiac pain and didn't have cardiac difficulties, and were able to be discharged safely to their GP. But the other 24% of patients were actually picked up by the ANP and very safely managed. The other example I have on this slide is about the advanced nurse practitioner and older person care, and this is an interprofessional team approach. And this was a particular Midlands hospital where they used this particular thing, whereas the team was led by an advanced nurse practitioner with OTs, physios, speech and language therapists, dietitian, chiropodist, all of that interprofessional team working to get the patients out within 10 days, because after 10 days, as you all know, patients then get further cognitive impairment and physical impairment if they're and these are patients that I should have said, sorry, that had either had a stroke or had a fall, so they'd had some significant sort of physical and some of them had assault of some description, you know. So once they got this very intense, led by nursing, it worked, absolutely worked. But all the literature will tell you about the enablers and the barriers. If we have strong leadership, so this is something we're looking at. We're looking at transitional planning, and I think that's something that we need to look at as well. That has been very good in New Zealand in particular. And one of the principles we want to be able to do is we want to be able to enable and facilitate nurses who come to Ireland and they can be recognised and having qualifications, because at the moment the current model doesn't facilitate that. But there are barriers, and we acknowledge them, and most of those are to do with culture and managerial issues, regulatory restrictions and financial barriers. So what we want to be able to develop is a critical mass of advanced nurse practitioners, 700 by 2021. We have a timely way in which we want to do it. We want to develop a broad-based educational curriculum. We want to have a credentialing pathway, which will be very new to us in Ireland, and we want to be able to support integrated education if we can. The model itself that we're looking at is a little bit complicated now in this particular circle, but we were delighted that this emerged from the evidence review that we commissioned from UCD. And what we're suggesting here is that our graduate nurses, they finish their education programme with a broad base of competencies. And what we want to be able to do is to create an environment where they can develop their capability. And the capability within specialist practice or whatever the area and environment that they're in, that they can then work towards being an advanced nurse practitioner if that is their choice. But we're suggesting that within the advanced nurse practitioner community, if we're only aiming for 2%, then 98% is the rest of the workforce that we're looking at. So we need to be able to develop the capability of those, and that's where the credentialing model comes in. And we have a facility within our legislation to be able to annotate these on the registration. So we have a number of pieces of work to be able to do that, but that's one of the things we have to do. But the education part of this, I think, is particularly important. We want the education to be able to meet service need, and the service need that I mentioned to you before. And we're basing it then on the 6 areas of person-centred care, professional ethics, professional leadership, consultation and collaboration, clinical scholarship and accountability, to be collected within a portfolio and through a credentialing model if at all possible. And the other big thing that we're going from is that Mary Doolan now will explain to you now in a few minutes as well, where the model that we have had in relation to timelines, and that what we're looking at here is we want to be able to support integration and service focus. And then they're the top lines of what I'm talking about here. Into the acute primary care, social care, and mental health services. So chronic disease management, one of our biggest challenges, and it's the same around the world. Older person care is another. And patient flow, and we're looking at patient flow as unscheduled care. So those are the 3 priorities we want to look at. 4 demonstrator sites that we're hoping to start this September. We're looking then at credentialed education, specialty certification. So in real terms, we're talking about a patchwork where nurses and midwives can pick up the particular qualifications. The column to the left there shows the particular registration competencies and registrations that we currently have within the Nursing and Midwifery Board of Ireland. And the thing that's going to be the big difference here is that we're moving from having to have 5 years in the last 7. We're inverting that from the regulatory point of view to make it the minimum of 2 years, because we're putting it down. That's the minimum as the education. We don't have any evidence to show that 5 years or 7 years or any other length of time is something that somebody needs. What we can say is that you have to have particular competencies achievement, and you have to have supported education within your clinical experience to become an advanced practitioner. We're not putting a deadline on particular timelines. And it's the same with the clinical nurse specialist, is we're saying that the minimum length of time is to do a postgraduate diploma at 1 year. And what we're hoping to achieve out of this is to get responsive deployment of appropriately skilled staff. We can determine where skills are required. We can then focus the education budget to meet service need. And we see this as being a retention strategy based really on the work that was done in the King's Fund. We also want to build in succession planning. We have to start building teams from our graduates through to our specialists to our advanced nurse practitioners, or even just the graduates straight to the advanced practitioners. We see that there's going to be efficiencies in relation to this, but our big focus is on access to services, hospital avoidance, integrated care and waiting list reduction through using the skills of advanced nurses. We see that nursing midwifery has the capacity to bridge the gap between access and coverage, to coordinate increasing complex care, fulfil the potential as primary caregivers to the full extent of their education and training, as was suggested by the Institute of Medicine, to enable the full economic value of nursing and midwifery contribution against the care settings, and change the reference point from which nursing and midwifery is judged. So I have one slide here that it'll be available that Mary can show to you, and this is sort of like the summary of the policy solutions that we say, well, what can be different? And it's really that we would maximise the skills for the graduate, would reduce the length of time for becoming an advanced nurse practitioner and an AMP, we move from an education based on current needs and priorities to meet our service needs. And we want to move to an enabling credentialing system that facilitates nurses and midwives and recognise these credentials through a portfolio. So in summary what I have, Mary, for you. So in real terms, we have an action plan then for the next part. We have a steering committee that is currently being developed. We have monies associated with this now for the next 2 years, where we will have to develop a paper then for the minister to be able to show that it's either working or not. So we're going to do demonstrator sites, and we're going to do then an educational pathway, and we're going to hopefully, that's going to tender then shortly. So there'll be an education pathway starting in September, and we'll also then have these demonstrator sites, and we'll have then a report to the minister 2 years later. So thanks very much indeed. Okay,
thank you very much, Anne-Marie.
And my question may well be nice, coming from out of the context of Ireland, but I watched this presentation early morning and now, but this time when I was looking at a question, because it's an integrated pathway in the 2 years, Do you see the 1 year trip to being a CNS as part of that pathway, or actually is it outside? Because the nurse practitioner that you're producing doesn't necessarily have that specialty focus. So that if you did a year, got a grad to become a nurse specialist, you'd still have to do the full credits to become a nurse practitioner.
Yes. Well, it can be part of it, because I know that there are some of the models that the advanced practitioner is only 1 year as a graduate. So some people have developed, and like that, it's really part of this credentialing framework, so that within the credentialing that you can create the skills, because there is a need for some of the specialisations, and some of the nurses themselves really they adhere so much to the specialisation, and they want that specialisation. But at the same time, what we were seeing kind of within the generalist broad base is that the assessment skills, you have a broad base of assessment skills, you have a broad base of decision-making skills to be able to interpret what it is that you find then from that assessment, and that you have the skills then to refer, and to appropriately refer, because I see that nurse practitioners in particular will be referring people to other services. And they'll be able to coordinate particular episodes of care. But I think that's really, and that's actually one of our policy challenges, is actually to look at some of these referral pathways, because it'll be new to some of the services to be able to do that. So
just to follow up on that question for clarity purposes, are you suggesting, Emery, that to become an ENP there can be many ways to
absolutely
become?
there is.
Okay.
That's right.
You can go the specialist route, or you can go the generalist route. There is no right way.
That's right. That's right. And a lot of it will be determined on, some of it will be on service need, because in real terms what's happened is that to date, and this is in no way sort of like as a criticism, but it's a lot of it has become sort of specialty associated with a particular consultant, or a particular sort of, as opposed to looking at it from a service-wide point of view. So if we developed sort of 30 or 40 advanced nurse practitioners in older person care, that would make a massive difference, as opposed to having one advanced nurse practitioner in one particular geographical area, and she's doing wonderful work, or he's doing wonderful work in that particular. But if you had sort of a 30 or 40, you know, it could actually make a huge difference, particularly to the communities that are working in the nursing home sector, and support them. Yeah, and keep people where they want to be, at home. Yeah.
Following up from that, just while it's fresh in my head, are you anticipating that all advanced practitioners will be prescribers?
Yes. More than likely. Well, not coming back on the same point, Mary. It's not absolutely, but the majority of them we would anticipate would probably need to have prescribing rights. Yeah. There'll be a few specialties where it wouldn't be necessary, but you know what I mean. I'd say the majority of them probably would need them. Yeah.
Okay. Any more questions?
Rita.
Thanks, Anne-Marie. I mean, it's really interesting, and I think it's great to be at this cusp of change.
Well, discussion of change.
Yeah, or maybe moving into a process of change. But and maybe it's Susan's model. It's more, I think, Susan's, or when I say Susan, the community focus. Or my interest particularly is in chronic disease management in pathway. So currently we have a cohort of CNSs in heart failure and CNSs in respiratory, and when they were established within the clinical care programs, they were appointed at CNS level, and that cohort are a very experienced cohort. Many of them have already done the masters, and they're ripe to move towards advanced practice. So I'm wondering, is there any vision for those people already there who are ready really to move into advanced practice roles? I've spoken to a number of them. One particular, is a CNS in respiratory. She completed advanced practice master's here a couple of years ago. Funding hasn't been available for an advanced practice post. There was a kind of a blurring because it was a CNS outreach respiratory. It's working really well, and it's working so well she was loath to leave the CNS post into an AMP because she loved this, and she was doing it really, really well. But really, for all intents and purposes, she was operating at advanced practice level, if you know what I mean. So in a way, I feel they're a little disenfranchised, and I'm familiar with a number of the heart failure nurses in the St. Michael's, Loughlinstown, St. Vincent's, are partners, and many of them are CNSs, and I'm wondering just how we can lift them up. And maybe that's a separate question to this, but I think it's really important that we don't forget them.
I'll tell you now what it is that going back to the circle, that we can only have 2% of the workforce as advanced nurse practitioners, and they can't be providing that full service on the home. What we need to be doing is creating so that there's a full team approach, so that there's graduate nurses working within that service, there's specialist nurses working in that service, and there's advanced practitioners working in that service. So it's a service, it's a nursing service that embraces its own succession planning model. So within it, that each one is teaching each other. So it's not just one nurse sort of who flies in and flies back out again all the time. That this is a service that can be managed over a particular extended hours of time, particularly within the community, because we would like to be able to see that the primary healthcare centres, which currently work very much in a 9 to 5 type of a service with some public health nurses, you know, providing services at that time, that there would actually be a permanent nursing service between 8 to 8 on the initial phase of Susan's implementation, and with tele-triage then until 10 o'clock at night. So that's and we'll be doing it 7 days a week. So that's what we're hoping to do now for the first initial kind of rollout. And that can't only be serviced by advanced nurse practitioners. That has to be serviced by graduate nurses and specialist nurses and advanced practitioners. So it's about developing that as a service as such.
Yeah,
thank you, Emery. I love what you're saying, I suppose, about the team, because at the moment, as you might say, we have one AMP in certain services, and really then they're not there, and suddenly you see the clinic is cancelled or the patients, you know. And only last week, Dr. Barry White, who was asking me about this, and I said, it's not even just succession planning, it's team building and building a team that for the service need. And I think that's really where we have made great strides. As you say, I really like what you're saying about the future, because we have to look at it with the whole team, as you say, interdisciplinary, not just the AMPs, but certainly more than one. We have ones floating, and you know that, Lucille, as well. You know, we have ones in certain services that really, it's for the future. It can't sustain. They can't sustain that either. Yes, as well.
Any other questions? Talk to us a little bit about the 4 demonstration sites that you mentioned there.
Well, we're setting up a steering committee now, Mary, that the Minister will be appointing people to the steering committee, and the steering committee will then, I've collected all the data in relation to waiting lists, to presentation times to EDs, to the problems that I've mentioned. So they will be the criteria upon which the demonstrator sites will be identified. So that there's a criteria sort out, but the steering committee will do that. So the steering committee will be supported then by 5 working groups, one for education, one for regulation, one for governance, one for service need, and one for five.
Okay, so there's criteria for these demonstrations.
Oh, absolutely, there are indeed, yeah. And one of the things will be that we can create a critical mass, and that we can and geographic spread. So that's part of it. But also will be the support that can be given then to the nurses themselves, who will be part of this. Yeah.
Okay, and one of the questions, I suppose, from the launch in Ballymun was the current advanced practitioners that are out there. They were wondering what's in this whole transition for them. They're currently working, and is there anything in this new proposal for them?
For the nurses who are currently working as advanced nurse practitioners?
Yes.
Yeah. Well, we could see that they can be the mentors and the supporters then for the new ones coming up behind them, and that they will be in that same, and also that hopefully they will see then there's an opportunity to develop the team behind them, so the succession plan, because we're actually going to have a difficulty with the 200 I've mentioned already, Mary. We're going to lose about 1/3 of them now in the next 8 to 10 years because of the age profiles that we currently have. So even at the best will in the world, we'll be running to standstill, if you like. If we left everything completely static at the minute, we'd be only running to standstill.
But I also know that you kind of have mentioned there of if they wanted to progress.
Oh, that's right. Into if they themselves wanted to develop their own pathway, particularly within sort of the research arena and sort of the clinical research in particular, into the doctoral level, that they could then be they'd be arrived. That's
so
right.
This is a kind of a complete model, really, from RGN right up to in terms of academic progression.
Absolutely. It supports academic progression, and like that, then the nursing creating its own community then of people who can sign them off as competent.
Okay. Angie.
This is a wonderful opportunity. I mean, it's a huge policy window that you and the department have pulled this through, and with resources as well. it creates so many opportunities. And I've just been reading about the DMP stuff, and one person was quite critical of it said the really good thing it's done is give nursing a shot in its arm to look at scholarship from birth to death, if you like. Yeah. And this really gives that opportunity, and I was just wondering if it's going to be facilitated as part of this process to actually look from the day you enter the bachelor's degree to the terminal point, which I think is a bad term anyway, because a lot of people go and do stuff after doctorates, but to that doctorate so it doesn't become ridiculous. To look at these capabilities, we haven't heard about the new standards yet, but I'm assuming that's got capabilities or competencies, and to map where in that journey that the person develops those, and then also map up to the work to be done, like you said, in that workforce profile between the graduate and CNS.
Yes. Well, we would see that, and like putting it in the policy like that, there's a recognition that there is a pathway and that nursing can manage it, you know what I mean? So that's...
I was just thinking, and I was telling you the other day, but Mary told me about the 2 tram lines in Dublin that when they built them, they didn't match up in the end. If we did this in Australia, and we'd find we've got the same thing, is that there's expectations, but there's tram lines that don't connect. And I was just wondering if this, because it's such a unique opportunity to look at the full workforce profile, whether part of the funded activity or is going to be that review.
Well, like in real terms, that nursing is the largest community within the health family. Like it's 40% or 39% of the health family. So if we can make a sort of a bigger contribution, that sort of, and particularly when we're going to come into such stretched things with us all living longer, all getting sicker, and the biggest challenge, of course, then is the financial one that we currently have. So how are we going to manage these services into the future? So yeah, hopefully it'll work.
Okay.
Can I ask, Anne-Marie, to date, like we've only 0.2%, do you think some of the barriers within, say, hospitals and that is the financial cost of having an A&P?
It is.
You know, for the smaller hospitals, that it's an add-on position. So I'm sure there's a lot more A&P posts and there are a lot of people who are on that pathways, but it is getting the financial, you know, I suppose money to pay them in that position. And as Rita's already said, you know, it's one A&P alone runs a service, but when they're on annual leave sick, you can see how it falls down, where when there is a team, it works so much better. So for smaller, say, hospitals, financial, would it be?
Well, that's right, and you've hit the nail on the head in that we know that there's 47 A&P vacant posts currently in the system, and like that, finance is the main reason that's given for them not to be filled at the moment. So I think like having this and sort of leading, if you like, from the policy direction, then and having people supporting it at this level means it can go into the service plan for the HSE for next year. So we're looking at the HSE having to have a KPI to be able to show and demonstrate where they've put in those 120 places.
So it's only recurrent.
Pardon?
These are all the just thoughts I have as things go up, but I was just thinking then for the HSE, for a hospital director of nursing, is the funding only going to be for 2 years and then they have to find funding for it? Or if they get a post in, is that recurrent funding then that, like, we'll just roll from budget to budget?
Well, at the moment, the commitment is for the, like, once they put it in, the system is here, you can't take it out, and if somebody gets the post, that will have to roll. But there will be a revision of it in 2 years' time as to whether they'll make the continue the commitment for the following 2 years intakes.
Secure, it's whether there's going to be another 100 pull-outs.
Actually, there's 250 secure.
I guess the key to that, Andrew, is then how we demonstrate the impact of these roles. That would be very important.
Yes, and as I was going to say something, I was going to say in relation to the maternity hospital, and we very much have our specialities are linked to the speciality rather than to a consultant, which I hear more in the general hospitals, they're consultant links. So it's very important that the posts are linked to a speciality and not a specific consultant or GP, you know.
Yeah, well, that's community. Yeah, well, what we're trying to do is actually to a service need. Yeah. So if it's for chronic disease management, or if it's for unscheduled care, or if it's older person care, and like that, even between the 3 of those, like the assessment skills are fairly common to the 3. You know, it's actually what you do with them is where the difference is, because you're going to use the same sort of diagnostics, you're going to use some of the same interpretation skills. But it's actually what you do with it, you know what I mean, the physical do is where the difference is really going to be, I think. So no, you're quite right, yeah.
Okay, if there's no more questions and I didn't get any ones typed here, we will close Anne-Marie's session, and I think Anne-Marie, you can stay with us for the next one, or can you? You're more than welcome.
I have to leave it too.
You have to leave it too. Okay, well, we'll come straight in.
We've had her all morning. So.
Okay, everyone, we're going to follow on with Dr. Mary Doolan.
Okay, so good afternoon, everyone, and thank you very much, Mary, for inviting me here this afternoon. We've had a wonderful morning with the Masters students over with Eileen and Rita, and we had a fantastic presentation from an RAMP in stroke care. It was really, really good, and it informed, I suppose, our whole, my session, and certainly Anne-Marie's as well. It was very, very good. So, yes, in the board we have 217 RANPs, registered advanced nurse practitioners, and 8 RAMPs. And I suppose when it comes to the standards and requirements, the history is a working group of advanced practice was set up in 2014, and I joined the board in 2015, and at that stage we had one document with nurses and midwives all on the one set of standards and requirements. But I suppose the midwives base their standards on the 5 principles, whereas nurses, we have 6 domains. So we went to public consultation with 2 separate documents, the nurses with their 6 domains and the midwives on 5 principles, and we got a lot of feedback. And at that stage, the Midwives Committee decided that they would develop their own document in terms of advanced practice for midwives based on the 5 principles. Now, Dawn Johnson is the Director of Midwifery in the board at the moment, and she's leading out on that. And the advanced practice nursing, we have now gone to, we've had it approved. So we have our standards and requirements for advanced practice nursing. Now, they're with the designer at the moment. These are our nurse registration program standards and requirements. These are our undergraduate standards and requirements. These come into operation on the 1st of September 2018. And what I'm going to talk about now, the advanced practice nursing standards and requirements, I have them up, but they're only draft. They're with the designer at the moment, and they will be up on the web late this week or next week, okay? And we've defined advanced practice as a career pathway for registered nurses committed to continuing professional development and clinical supervision to practice at a higher level of capability as independent, autonomous and expert practitioners. RAMPs have met the board's criteria for registration to enter the advanced practice division of the register. And going back to 2014, Professor Mary Carney led out on the literature, an extensive literature review, and I know we cited some of your work, Professor Cashin, in terms of the standards. So as I said, the standards and requirements were approved by the board just in March, and if you were to break the document up, I suppose you'd get the competences are the first part of the document, and then the standards for approval of HEIs, associated healthcare providers, and education programs leading to registration is the second part of the document. And that part of the document, Mary, you'll be very familiar with the post-registration standards and requirements, and we really just have deep linked the post-registration standards and requirements. But also we've added in specifics in terms of clinical supervision, in terms of clinical competency, working group with the healthcare providers, so that it's very much at the end of the day that they're bespoke masters, I guess, to meet the need in terms of clinical competency. We, I suppose, in the board had legislative authority since 2010 in terms of advanced practice. Prior to that, it was the National Council. They determined 4 core concepts, and then the National Council was dissolved in 2010, and legislation Statutory Instrument 3, Statutory Instrument 689 empowered the board with additional functions. So what we do right now is we determine applications for accreditation of posts. And we also register nurses and midwives as either RANPs or RAMPs. So it's very, very clear in the legislation. Those statutory instruments specify out exactly what it is we do in the board in terms of our role. And we continue to accredit posts, which in some ways, I guess, has contributed maybe to being a regulatory sort of inhibitor, because at the end of the day the service should determine what advanced practice looks like. So very soon that piece of legislation in terms of accreditation of posts will no longer rest with the board, and it will be back to the service, and the directors of service will determine what areas they need to develop. So we're currently on our website, you'll find a consultation in terms of rules, and these rules will revoke Statutory Instrument 3 and Statutory Instrument 689, and the new rules then will specify the rules board. the role of the board rather. So as I say, going back to the National Council in 2008, they identified autonomy, expert, professional and clinical leadership and research as the 4 core concepts for advanced practice. And we've been working with those continuously since then, since 2010, since it came to the board. Going forward, as I said, the 4 core concepts will be replaced by 6 domains of competence and standards of practice. The transition, we recognise, will take time, so any nurse who has commenced his or her portfolio, of master's students who are nearing the completion of their portfolios, they won't be expected to change to the 6 domains, they can still stay with the 4 core concepts. We are meeting in the board, the executive in April, and then in May we've planned to bring forward processes in terms of timeline so that it's very clear in terms of when the 4 core concepts will be phased out. So here we have like our model for advanced practice. So if you look, its foundation stones are at the base, and philosophy of nursing, that's actually values for nurses. So that goes back to Anne-Marie's session in the Department of Health. They have a position paper whereby we worked with the Department of Health and the UNMSD and the HSE to determine the values for nurses and midwives. So we've care, compassion and commitment. So what we're saying is all advanced practice services going forward should be built on the philosophy of nursing with care, compassion and commitment at the core. Commitment then, I suppose, is to do with, you know, a vision for advanced practice in terms of service and the work that's involved in preparing a service for advanced practice. Governance for quality in terms of making sure that there is a professional line and that there is a clinical line in terms of accountability. Memorandum of understanding and service level agreements are also there. Autonomy and accountability, because you are working at a higher level, you must be able to take accountability for that. Policies, procedures, protocols and guidelines are there. Referral pathways, that these are already established. Clinical supervision in place, responsibility for practice, collaboration, again, no one works in silos, so therefore you must be able to collaborate with the interprofessional team, and that you have a caseload in terms of autonomous practice as well. The 6 domains are the highlighted there. As I said, they build on the 6 domains, and maybe that answers your question in terms of, you know, the career pathway. So down the line, you know, we're not starting this new standards requirements until 2018, but nurses coming into the system in the future, they'll start off at 6 domains and then they can build on the 6 domains right up to advanced practice level. At the end of the day then we see quality evidence-based sales, person-centred care and a higher level of capability whereby people have vision, they have the competencies and then that they're able to expand their practice to meet service, resulting in enhanced service, health services demonstrated by RAMP performance outcomes so that they're constantly reviewing and evaluating. So the 6 domains of competence, then domain 1 is professional values, as I've mentioned, and the standard there is that the RAMP will apply ethically sound solutions to complex issues related to individuals and populations. And I suppose what we wanted to do there was to be explicit in terms of what distinguishes a CNS from a registered nurse to an RAMP in terms of complexity. So the indicators then, and these are cues, which are accountability and responsibility as a lead healthcare professional. So RAMPs in Ireland are lead healthcare professionals. They articulate safe boundaries, but they can timely refer and collaborate with others when the patient or the person presenting is outside their scope of practice and their capability. Demonstrate leadership by practicing compassionately and articulate and promote the role in clinical, political and professional contexts. Clinical decision making then, and the standard there is the RAMP will utilise advanced knowledge, skills and abilities to engage in senior decision making. So in other words, the cues are that you have comprehensive holistic health assessment, synthesize and interpret assessment information, demonstrate timely use of diagnostics and exhibit comprehensive knowledge of therapeutic interventions. Domain 3 is knowledge and cognitive, so the RAMP will actively contribute to the professional body of knowledge related to his or her area of practice by providing leadership in the translation of new knowledge to practice, educating others, demonstrating a vision through research, critical thinking and experiential learning, and demonstrate accountability when considering access, cost and clinical effectiveness. Domain 4 is communication and interpersonal, and the RAMP will negotiate and advocate with other health professionals to ensure that the beliefs, rights and wishes of the person are never compromised. by communicating effectively and share in accordance with legal, professional, regulatory requirements. Leadership in professional practice, so there's plan of care, and this is shared with the person and other members of the interprofessional team. Facilitate clinical supervision and mentorship. So we mentioned this already in terms of RAMPs providing clinical supervision and mentorship to their colleagues. And utilise IT to record all aspects of care. Management and team competencies, then the RMP will minimise and manage risks to people who access the service and staff at individual, departmental and organisational level through collaborative risk assessment and promotion of a safe environment. I suppose that's new in terms of it was in the other 4 domains, but it was less explicit. But as an RAMP in senior decision making, we want the RAMP to be at the senior decision making level and equally to be involved in risk assessment by promoting a culture of quality care, proactively seeking feedback and implementing practice changes. Leadership and professional scholarship then is the last domain, and the RAMP will lead in multidisciplinary team planning for transitions across the continuum of care. So to demonstrate clinical leadership in the design and evaluation of services, engage in health policy development, identify gaps in the provision of care and services, and lead in managing and implementing change. So advanced practice nursing is all about the patient having mutually agreed goals built on the values for nurses and midwives, care, compassion and commitment and the philosophy of nursing. And whilst there is great emphasis on outcomes and reducing waiting lists and positive outcomes, we also value the nurse-patient relationship, the therapeutic relationship, so it's not just about encounters. As I say, the current process is that we are still accrediting posts under the current legislation that is moving back to the service. However, it will still have to remain in place. This will be a challenge for directors of nursing and the service and directors of midwifery in terms of resources, culture, leadership, policies, procedures and guidelines, making sure that there are MOUs and established preferred pathways for RAMPs and RAMPs, clinical governance, quality and risk management and continuous quality improvement. Right now, we, as I said, we accredit posts and we also register people based on the submission of a portfolio and an application form. Within the legislation, it states right now that you have to have an offer of employment, so you cannot go into it's that tightly regulated currently, that you cannot take up a position and register unless you have an offer of employment. That will soon change. If you were to come forward today or to the May meeting, that you would have a master's level or above with a substantive clinical component, clinical supervision, at least 500 hours done already, 7 years post-registration experience, 5 years in the specialist area of practice, meet the 4 core concepts that I've mentioned already from the National Council, a commitment to continuing professional development. We go through the portfolio to see what you've done in terms of continuing professional development, and your arrangements. They usually have an MOU in place for ongoing clinical supervision. We have revised our criteria for registration, and our criteria as approved by the board in March 2017 is that you hold a master's degree or higher in nursing, or a master's degree which is relevant or applicable to the advanced field of practice. The master's must be at level 9, our national framework of qualifications, and it must include at least 3 modular components pertaining to the relevant area of advanced practice, in addition to your clinical practicum, which will demonstrate that you have been deemed competent in your clinical competencies. You have your evidence of 500 clinical supervised hours in the specialist area of practice, and that you demonstrate the competencies for advanced practice in your portfolio, the 6 domains, the 6 standards that we've identified. The board will focus on the achievement of competences as evidenced by the applicant's portfolio, their transcripts received from the HEIs. A lot of this happens already, so if someone is coming forward with their masters from Eileen and Rita's program right now, they have their transcripts and they equally have the clinical hours in terms of the 500 clinical supervised hours and the clinical competencies. And we've introduced a new criteria now, which is passing an assessment by approved panel. Now, the operationalization of this has to be fully agreed by the board at the May meeting, but the person coming forward for registration will come in front of an approved panel, I suppose, to give them an opportunity to demonstrate, how they've achieved their competencies and that they have the standards or achieved the standards. Right now, we take a report to the registration committee in terms of post-accreditation, and equally the portfolio with the report goes forward to the registration committee to register in the division of the register. So I suppose there's opportunities and challenges for everybody going forward in terms of the board, because we have new processes and all change brings with it challenges and opportunities. I think directors of nursing and midwifery will also have challenges. HEIs will have challenges, and equally, as we've heard from our master's students this morning, you know, they perceive that there are challenges with change, but at the end of the day, it is about enhancing outcomes for our patients and improving the service. Thank you.
Okay, thank you very much, Mary. I'm going to leave it open to the people here and to the people on the webinar if you want to type in or ask any questions.
Mary, you said the AMPs have come from 7 years experience down to 2 years. Is that 2 years experience within the speciality?
Now, we haven't specified 2 years at all.
Oh, sorry. Oh, okay, that comes
so
from
what we are doing in the board right now, I do count, right? Yes. I do count right down to 5 years. Okay, so we're moving away from that, and what we're looking at is that you demonstrate your competencies. So we're not saying that it could be 2 years or it could be 20 years. It's up to the person to determine when they can demonstrate to the board, if they want to go onto the AMP division of the register, that they achieve the standards as specified in standards and requirements. So we've actually moved away from years altogether. And Anne-Marie would say there's no evidence in terms of years of experience. And I suppose my short time doing this, you know, some people, it takes them 10 years, not because it's taken them 10 years to achieve the competencies, but because of other factors. But from the board's perspective, we are looking at competencies and demonstrating your competencies.
Thank you very much, Lucy. Any other questions? Eileen.
Thank you, Mary. Can I ask you about the 500 supervisors? It's interesting, I suppose, in relation to the year's experience, and now I'm going to link it a little bit with the 500 hours. Because as you know, and we have that integrated into our program, but you know, it's always a challenge sometimes in the, if there's a person in an advanced nurse practitioner candidate post, it's very easy. I don't mean easy, but it's easier to accumulate those hours. We have many people, as you see from our students this morning cohort, we have many people who are in, you know, CMN2, CNS roles. So how, I suppose, going forward with this, and it's wonderful what's happening and changes, and we really do embrace them. I think the domains are very clear. But just in that clinical decision making complex, how we get the students to have the 500 hours. And I know they have a mentor, but in some ways, you know, and it's not the person standing over them, but sometimes that can be a challenge for some of our students, depending on their role. Now, they get there because they have to get there to get to you, don't get me wrong, but no more than the years might be. Where's the 500 hours, I suppose, as well, you know, in the evidence of that to be the right number of hours for these students to become registered. Do you understand what I'm asking you?
Yes. Many of the students coming forward, to be honest, would have much more, and the majority would have much more. So I suppose, you know, the 500 hours has worked.
Yes.
And people are competent, and we've had absolutely no issues in terms of competency. So we didn't change.
Yes.
And the majority come forward with 1,500 hours.
Yeah, I agree.
You know.
Yeah.
So,
Rita, do you want to come in there?
Oh no, sorry. Yeah, I mean, sorry, Mary. Yeah, I suppose the challenge is. Currently, a lot of people, as you say, Mary, and thank you, and I really embrace the changes as well, and the indicators think it's really, really good. 500 hours, we're retaining the 500 supervised clinical hours, is that correct?
To achieve competency.
Yeah, to achieve competency. And Eileen and I have been discussing this a little bit recently because, say, our applicants for the programme for next year, just for our, you know, to present as it is, and I'm in a staff nurse position and I want to do the Master's Advanced Practice. It's difficult for me to get the time out of my staff nurse's responsibilities, role, job within the area to actually to get the supervised hours at advanced practice. Do you know what I mean? And that has been challenging. So if I'm self-directing and I go forward to do the Masters, which I can do in the future, I understand it, isn't that correct? Without a role or without a post or a candidacy or whatever. Yeah, it is a conundrum actually now that we think about it, the clinical supervision hours. So perhaps, and you know, perhaps in operationalizing this, people will be in CNS posts or moving towards experience posts. To get the time out for the clinical supervision.
In many ways, the reliance will go back more on the employer to ensure. I don't know, because at the moment, because you credit the post as well as the person as well as the person in the post. When you separate that, the employer will have to have more. I don't mean governments, they have at the moment, don't get me wrong, but they'll have to have more of a say in ensuring before the person presents to you, become registered at 500 hours or they're protected on the course in many ways with the 500 hours.
Because the Director of Nursing has signed them up to support them on this Masters. A part of that Masters is having time out for supervised hours. So, you know, in an indirect way, they can get the hours as a staff nurse.
Is that current 500 hours supernumerary? No.
No, working at supervised, working at an advanced level, reflecting on cases, or but doing something different than you're doing normally.
But hopefully that the directors of nursing will have the vision that these people will need support, and if they want advanced practice, that they will support them, because your fear is that they will come forward of their own and think this is a career opportunity. Yes.
Well, there are, and I suppose maybe we need to knit that with the HSE and the GOH, because we have people, like there is a staff nurse on one of the Masters despite she has a letter from the DON and support, getting time out to do anything at an advanced practice level, and she has total capability to do it. You know, she's fine. She's well able to do it if she gets the chance, but she still has to do her job. Sorry, Andrew.
This opens up a very realistic and probably much needed prospect, which is the same as the prospect in the way you do it in America. Or the same as now we've got 300 supernumerary hours in Australia, is that it's not tied to employment. The student could come and enrol full-time, and your responsibilities at university would be design practicums as you would in the BN, supervised through university staff, whereas the HSC is the hosting agency, just as they are with the undergraduates. And that way, the benefit, of course, is that the person can really focus on capability development. The supervisors, with their tie to the university, aren't just, well, you're an MP, you can mentor Sally, even though we know that we might not have spent a lot of time developing your capability as an educator. You're an expert clinician, but are you an educator? Whereas if you're employed by the university, you are. And so the assessment, you've got it down pat. You can really consciously then integrate your program where the small amount of time, and I mean some of the questions they'll raise, which are just questions of how do you do the core modules, plus all this other leadership and research and things that aren't necessarily taught in a bachelor's degree or a special grade deal. How do you develop those sort of higher order capabilities, which are very much part of the standards for practice and the competencies, at the same time as the clinical competencies of, you know, advanced assessment, if you like, ordering diagnostic investigations, being an autonomous prescriber as opposed to collaborators. So the only way to develop so much in such a small bucket is going to be to optimise your clinical practicum. And really that's not going to be an employed model. It's going to be stepping out. And so even if you are in a candidate role, you may have to go to different departments in the hospital to build up skills, or different hospitals. You may be a child's nurse. And you want to develop skills in early psychosis intervention and assessment. You may need to actually leave your department and go to the psychiatry department for a period of weeks to get that exposure and capability development.
Which works well, Andrew, because these are employees of the hospital, they're part-time students, as you know, our advanced practice students. And while it works well with the advanced nurse practitioner candidate, but only 50% of our students, and that's high for this year, are in an advanced nurse practitioner candidate role. The rest of them are in their normal roles while trying to make the transition. And so the candidate people can move, they can go to another area. They have and I always say to them, they're in the lovely position.
Luxury.
It's a luxury, because every hour they do is advancing practice. But for us, you know, we have Roger, for example, who one of our students who's in a staff nurse role, pulled on to night duty sometimes, you know. Now, the nursing management in the hospital are wonderful at trying to support, but staffing problems. So we don't say. So this is where...
But with the new changes, this is what I'm hearing from the outside, a student doesn't have to be employed any longer. They can come and enroll with you.
Yeah, so even more challenges now, because they can...
Which is what I'm sort of thinking is that this actually creates an opportunity for we step out of that box when you're looking at hours, because you may get students who come here, they may well be employed, like most of our full-time students are employed part-time to get the money, but that employment has nothing to do with their capability building, it's just what they do to pay the rent. And they come and study with you either part-time or full-time to do the nurse practitioner business.
There are those students going, like say from a hospital perspective, we would have those going to an A&P. They're fully paid employees for 39-hour-a-week role, where our student midwives are paid, you know, differently because they're students. So these are A&Ps that are paid to our 39-hour week. So a lot of them do their study as extra. So their clinical time, because they're candidate A&Ps, they're in an area that they are doing their, you know, their clinical supervision, and they're doing all of that because they're in that hour. So that's part of their workload. But if they worked in a different area of the hospital, they can't leave where there's so it causes problems, as you said.
Actually, it's just hearing from the outside, is we get very locked into what we used to. But this doesn't have to be that anymore. In fact, the student who comes and they're studying part-time, just like if they went off and took themselves to be a vet, the director of nursing doesn't have to pay them to go and do their clinical placement in a veterinary clinic. You know, they're changing professions. This is exactly the same. They can be working full-time or part-time in a HSC and doing this nurse practitioner course. Well, to develop their hours, they may have to take leave. In fact, we would expect them to take leave because that's part of their course. So this opens, the changes you're having opens up that new way of thinking, which is actually de-linking employment from the course in a way, in that, because and this is this rhetoric I'm hearing that, or not rhetoric, but the ideas, because you're working in an emergency department, but the skills that you're needing to build to go out and work in one of these walking primary care clinics. And so you want to plot your career path within compressed time. I want to go from here to here. Well, I don't have to wait for an employer to give me a candidate's role or to give me some sort of compensation. I can make this, well, I'm going to go and UC down and do the masters, and I'm going to plot myself to this position. Well, just like any career change, it's going to be a sacrifice in terms of financial stuff. But like you said, at the other end, I'm going to balance it because I'm going to get an aid on equivalent wage, and maybe I'll even get some shift penalty. I don't think we can do that. But I'm going to invest, and so I don't have to rely on my relationship with my employer, other than perhaps they'll give me a blessing that I can have my holidays to do the clinical placements.
It actually would also take back and say, if you don't do your clinical in the organisation you work in, it looks into your indemnity to work within your organisations to do clinical assessments and clinical supervision. So say where I work, in the hospital I work, and if we had somebody who was doing a speciality that we have come from another hospital, then it'd be the clinical their indemnity, but also we would have to resource somebody to supervise them and take that role on as well. So there's all those.
No, it's not really when we think about it, because we're jumping out of our box of thinking. And that's a good thing from the outside, because you're still thinking we're employing this person. But if they're doing a course, it's UCD that has to indemnify them, and this has been a real challenge in Australia.
But supervise them on the clinical sites.
UCD, just like they do the undergraduate program, I assume they've got clinical facilitators, or they pay hospitals.
Not meaning to cut it, the discussion, because it is a very important point that you're both raising, because we're in that space of indemnity and making sure that, you know, all the patients are protected, as well as the student and the organisation. But you're also raising a very important point, I think, in terms of the path that we knew of becoming an advanced practitioner is no longer the path. And this was the point I put to Anne-Marie. You can get to becoming an advanced practitioner through a number of routes. And that does bring its challenges, because you can do any number of master's programs 2 years after you qualified or 10 years after you qualified, and the 500 hours, I think it's an interesting point that Eileen raised about where is the basis for it, but nevertheless it is what we have. And the requirement is for the student to produce the evidence of having attained those 500 hours. So there's an element of putting all of this back to the student and the student's responsibility and motivating the student, which isn't such a bad thing, I would think, in itself. What do you think?
You know, I'm pushing my own barrow, but actually, You know, think of my position. I'm a nurse practitioner in practice in Australia, but I can't come to practice in Ireland, but I decide I'm going to move here. And so I go, well, I want to do this course. Theoretically, the way it's structured now, I should be able to go to UCD and say, I want to be an advanced practitioner. And it can be a prerequisite I'm employed, and you can set it up that way, but it could be like the United States where they go, fine. You know,
I'm just going to say, Lazarina and I did our advanced practice modules in the University of Pennsylvania. That's exactly when we started. We come with all this experience. Lovely, lovely people working with. I don't know yet where I'm going to work. I'm just going to see, you know, I'm going to primary care. We were shocked by these people who just done their bachelors, come into their masters, wonderful, wonderful nurses, but they were deciding while on the course where they would get their experience. So it's exactly the model you're talking about. I'm not too sure.
The same in Washington. We went over to Washington to do some advanced health assessment refresher course, and there's about 30 students in Georgetown on the Master's of Advanced Practice degree. We joined them for the module for the health assessment, and most of them were, you know, obviously self-funding, traveling from all over the States. It was an online program, and none of them had advanced practice posts yet. I mean, they were all quite young, you know, they weren't qualified. It was a whole totally different dynamic.
It's a different model, and that's what I'm talking about here, because the model is that the university controls the practicum, which means they control facilitating it through service agreements with the hospitals. The university indemnify the students, the university pay the facilitators to, so while they use Typhoon and things like that to, you know, collect information, it goes up to the university. It's not this tight link with needing to be employed, virtue of the fact that you could go over there and do it, isn't there. And so there's a different way of thinking about nurse practitioner education. Our move to 300 supernumerary hours, in a way, has the same sort of spirit as that. Whilst it's embedded in your employment and has all those contextual arrangements, then also things like indemnity and things are involved. Once you've got supernumerary hours, and once you've got a university program which links the practicum really tightly as just another way of teaching and building capability, it changes that. It's out of the indemnity of the employer. So if I say I want to be a nurse practitioner, then I have to work out how I'm going to become a nurse practitioner. So I can work part-time and study full-time, or I could have an arrangement where I'm going to use my long service leave and take myself off.
You don't get that.
That's Australian, no. That's not Australian love. Don't tease us anymore.
But you know what I mean?
We all want to know.
The employer is not responsible for me doing that course. I'm doing it on my own back outside, which includes the clinical placement. Someone has to indemnify me. It's not going to be their student. It's going to be the university, and it's going to be indemnified. Now, your undergraduate, and that's why I say context is different because of your employee model in your undergraduate. But then that question, when you look at these broad capabilities and you look at the amount of volume of learning you've got, you really have to be careful that that clinical practicum's integrated, and it's a very healthy part of your master's degree. And so then it allows you to start thinking about uncoupling all these people who are going to be part of the 700. Sounds like when they Spartacum movies, doesn't it? You know, the brave 700. Well, there's not 700 candidate posts at the moment, so there's actually a possibility to go from BN to nurse practitioner, and there's nothing in this framework that would prevent that. And you know, that sounds a bit outrageous, but when you look at it, it's quite true. You could go from your BN straight into your master's, and then if you can work out this clinic who would come out as a nurse practitioner, well, why is that a bad thing? Because they're going into positions that don't yet exist in nursing, into these primary health care models, etc., etc. So, I mean, I'm just throwing.
It's an interesting, no, it could be very exciting, all these people independently funding themselves, all looking for, watch this, Lucy, and all looking for their, but it would be a very, very, very different model for us here.
Thus we have hundreds of students who have just finished masters and who are ready for advanced practice and who haven't got any positions. So what enticement is there for people who are coming out, but people who have years of experience and masters and competencies and no post, no
finance.
So
can I ask you, Mary, in relation to, you said going forward the accreditation of the post will be back to the service providers.
Yeah.
So when we look at, so I work in maternity hospital, so there's only 19 in Ireland, so we're in a very smaller pool than the general. So say, as in our newly post, our new AMP post in emergency department, Would they be generic job specifics and job descriptions and job posts? So if you're an ED, AMP and ED and national maternity at home, that's very different to if you were down maybe in Kilkenny or the Wexford.
Yeah.
So is there going to be standardizations of these posts? Because you can already see, you know, certain people have different acuities and different levels of, I know there's an AMP level of responsibility you have.
I think that's where the ONMSD will step in
Yeah.
terms of, and they've done it already, and we discussed this morning, because the ONMSD have the project officers, and they're looking at it from a HSE perspective, and they have core job descriptions already, and they've developed different templates to support service. At the end of the day, if you're in the National Maternity Hospital, you have a different maybe population to even the Rotunda. So you have different specifics that you'd want the core, so you don't want to reinvent, but you may want specifics to meet the service.
Yeah, I suppose it's just like, yeah, it's like when I say one of the new AMPs that have been looked at is midwifery like care around the norm. This is, I think, a new candidate post that's looking around the normal midwiferys and clinics, and I suppose very much where I work now, our community midwives, that's actually what they do, bar being 11-9, all of them. But they're clinical and there are other areas. I'm just thinking where there can be conflict maybe around some posts.
But again,
Yeah, I know that's job specific.
And I think it's absolutely timely that the board step back from accrediting. In fact, you know, because that is the service and the governance, and that's where governance for quality comes in. So it is back to the service and back to
And I suppose we also need to be mindful that we don't just educate people to be able to work in the National Maternity Hospital.
Oh, no, I'm not talking about that. I'm just saying they should be generic. If you're an ED, that's what I'm actually saying. If you're an AMP and ED, you can work in any ED. And that's what I'm saying. I'm saying when we do credit our own, it could become that I don't want you're trained to work.
And it's continued professional development. I want you to do this year, maybe completely different in 2 years' time.
I think push people.
Yes.
And as an AMP, that's what you should be doing, that you lead out and you set up the service and then you educate others and then you move on to another piece.
Yeah.
Mary, can I come and ask you a question, coming with an educational hand? You said 3 modules plus clinical practicum. They have to demonstrate. What is that slide that you said?
So these are the criteria, the new criteria for registration, so that, and these would be in the standards and requirements. So if you're developing a master's in advanced practice, that you would have 3, say, advanced practice modules, right? And then you would also have clinical practicum. Because I suppose what's happening now is because we don't have standards and requirements, sometimes people may submit, HEI may submit a program and there's no clinical practicum. So they haven't achieved any clinical competency.
And what, I suppose my question on that is, I can go for the clinical practice. What constitutes an advanced practice module? I mean, do you mean it's a level 9, or do you mean it's
exactly what you're doing right now?
Decision analysis, theoretical, leadership.
Yes, but usually the research is maybe more generic, but you do your clinical decision making, advanced health assessment, clinical leadership, like they're already established in many of the HEIs in terms of advanced practice because of development specifically.
Core modules that sit under the new model that Anne-Marie was talking about, which are very clinical focused. Like you said, these are things.
So I think it's
diagnostic reasoning.
Yeah, but like person-centered care could be like it's an interesting.
But there's scope there, and we have very broad indicative content incorporated into the standards and requirements to give the HEI scope, because you might decide here, actually we're going interprofessional, we're going to do something completely different. We have 3 modules here, which will, plus here, obviously you need your other modules as well to bring up to master's level. We have 3 specific modules here, plus clinical practicum, and at the end of the day we can sign this person off as working at advanced practice level, competent to do so.
I think
without being too
very, say if people came with a degree in management or something else without specific nursing stuff or clinical,
you could
you could add on 3 modules like we do in the grad cert.
Right.
You know what I mean, or 4 and a practicum. So say you've already had a master's.
Which you're doing already, and lots of our nurses coming forward right now have a master's in something else, but they'll come and do their postgrad. Or
come to me in particular, I was looking at what Maria put up there, the person-centered care module or the autonomy module or one of those. if they were created, they would be at an advanced level. So that would be evidence enough. That would be acceptable, yeah?
I'm just thinking autonomy though.
Because if you look at, well, it's just a moot point, but if you look at the model that Anne-Marie put on, there's core concepts in that some HEI might decide, well, actually, you know, we're going to do a module on professional scholarship. Would that be an advanced practice module?
I suppose it depends on the learning outcomes, what way
that's fine. And the last question that I asked I want to ask is, a panel assessment, is that by way of an interview, Mary? Is that really what you're talking about?
This is new. They do it already, I think it's in New Zealand, and this is new because I suppose, like that, this is all very new for the board. So what we've decided right now that this is, you know, it's a means of, I suppose, enabling the candidates coming forward or the applicants coming forward to demonstrate what they've done.
Okay.
Yeah, it's an interview. It's not an assessment of competence.
Okay, so they have their portfolio, but then the final piece to register would be to present for an interview with a panel from.
Yes.
So if it's an assessment of competence, what's the outcome? How does the panel decide whether someone does or doesn't?
Because we'll still go back to, I suppose, the domains, but sometimes in the portfolio, even right now, you know, there may be, it may not be explicit. It's an opportunity just to clarify in terms of exactly what you've done to demonstrate a particular standard.
Rather than the panel going out, the people will go to the NMBI for this.
It hasn't actually been determined.
I know that.
Yeah.
Oh, yeah.
So
if the moment you go out, really,
well, see, we're doing site visits at the minute,
yeah.
And as I said this morning, you know, it's as much about meeting the person, because we present back to a registration committee. So if you've met the person and you've gone through their portfolio, you know the person and you're presenting them for registration.
Isn't it a recommendation as to, like, say clarify your portfolio? You're still looking for that clarity to demonstrate to you confidence that they've met.
Yes.
Competence. That's really a competency assessment by definition.
I suppose we don't want to undermine the HEIs in terms of, you know, that they will have deemed the person competent, but it's.
So if you find that you still can't get clarity, then you're still going to say they're competent?
No, we'll ask for further clarifications, and we may not take it forward.
And would that be done at the panel interview, or would it be done prior to that? When you send in, going forward, you feel people will send in their portfolios to review, and then there could be questions you would send back to clarify, and then come in for the meeting.
We'll still do the desktop as we do now. So when the portfolio comes to the desktop review, we'll do the clarifications, right? And then, so, you know, and it's over and back, and then we take the person forward. Whereas now we still have to do a desktop review, there'll still be clarifications, but they'll still come forward then for the panel assessment, which will probably constitute existing RAMPs.
It's a whole massive challenge, really. It's, you know, it's the more you think about it, the more, not that I want to see challenges, but if you think about our experience heretofore, and even our student, our colleague this morning, the RAMP in stroke who presented. Anyway, maybe I'm seeing challenges, too many challenges in front of my eyes just now. But if you think about her, or any of those, or our recent midwife practitioner in Holland Street, writing the portfolio and the caseload without the post, or without the vision, or without being somewhere. Yes. You know what I mean? From the ether, or from a more vague place, I imagine it would be hard to write your portfolio.
The cool thing is, and this is sitting on the outside, and I think it's a wall of string too. I think, you know, it's a point of opportunity of pulling it. Because before I get to what I was about to say, I was still thinking, because I've been on those panels, and I'm still thinking, well, what's the panel going to say? And it's either mastered or not yet mastered, capable or not yet capable. Go back and give us more. So it's really an assessment of capability or competency. You know, how will we dress it up at the end of the day? But I'm thinking about how do you do your portfolio. The beautiful thing about, well, the possibilities that this raises, similar to the Australian model and the American model and a lot of other international drifters, it's based on the capabilities or the competencies. So instead of it being based around employment, your portfolio is purely talking to how you address those competencies. And then that purely talks to the board and the panel, who then say, yes, you do or you don't. So it becomes capability rather than competency. Yeah.
And maybe then, you know, teasing out the caseload, you know, and the distinct components of practice is the next step in the journey. in establishing an advanced practice post and moving towards CPD within that model. You know, when you've established your post, then you can really refine your caseload. So maybe
Yes.
we're just doing it in a different way, you know what I mean, which is kind of interesting.
Okay, I'm going to call it there because we have Professor Andrew Cashin who wants to get. Oh, sorry, Andrew, do you want to get in there? Yeah.
No, I'm sorry, Andrew. I just want to say, I suppose,
This is better than mine.
using
Well, you haven't heard her.
using the model that we have, which is with our nursing and midwifery board, with our clinical and our healthcare institutions and the HEI, I just want to say Mary has really done a fantastic job with all of the work we've done, and I just want to compliment you, and I don't mean to take over, I just want to say with all of our graduates and how that process has worked. And I've been on many of the site visits because my students kindly invite me, or my graduates, our graduates invite us, and just to see the model, I do have to say it really is a wonderful collaborative model of how we get to the RANP process, even though we teach advanced practice. And I just think it's great to see now, okay, where we're going, but we still have really a very good model in how we work collaboratively.
Oh, and I totally agree.
Yeah.
And this morning, it's a pity in some ways you didn't come for, or you couldn't make for Patricia's session this morning, because she's just a year and a half in post and how she's even progressed.
Yeah.
But it is, the way it's set up right now is very good, and I think it's not going to change overly. Hopefully the policy paper, yes, and it is positive because the emphasis is on nursing and midwifery and progressing nursing and midwifery, and that's what we want. But in some ways, the ONMSD and what they've done, and equally, I suppose, in the board, because it is very much collaborative and linking back. And as Patricia said this morning, when she can take up the phone and ring you, Eileen, in terms of a piece of research, that shows it's really working. And she's a year and a half into post, because it's not just that you get through the program and you're gone. You know, you've built up sort of a relationship, and it is a small country, and we do all know each other. And at the end of the day, whilst we want everything to change, at the end of the day, it's not going to change overnight, and we're not going to throw out everything, because you know, many of the HEIs have fantastic programs as they are, and they're proved and they're working. It's just, I suppose, absolutely we need more RAMPs and to retain standards, which will happen.
Okay, thank you very much for that, and Eileen's very nicely thank you, Mary. So
I didn't mean to take over. That was more from an overall point of view, Mary.
We are delighted, and we all second that, and we're very proud, and we're sad that Mary's thinking of ending her time with the NMBI, but I'm sure she's going to go on to greater and bigger things. On that note, I'm going to hand this over to Professor Andrew Cashin, who wants to, for the next 40 minutes, thereabouts, just help us to tease out some of the issues and maybe give us some other issues coming from an international point of view. And
I should introduce myself. This is where I live, just in this group of houses to the left of the break hall there. That's Ballina, similar to that name over near East Key on your west coast. It's spelled the same. It's a small community in northern New South Wales. We're 1 hour short of the Queensland border. We're probably about 10 beaches south of Byron Bay. There's a picture of me with a little visitor that came just outside our office, and I was trying to keep a respectful distance away from the wildlife, and the little koala came and ran up and stood right next to me. So that's actually, when I look at this photo, it reminds me, and Quincy, we've been Facebooking friends back home, and my mate Marty spoke to me the other day, and he told us the unfortunate news that Mary's husband Bob had died. Do you shorten Robert to Bob? Yeah, Bob. Yes. So Bob had died. Now Mary's well into her 90s, and these guys have been married for somewhere around 60 years, and Marty rang up. He works at the North Coast Advocate, which is our little newspaper that services our town here. And she rang up and wanted to place an ad for Bob in the obituary, and it was pretty sad. And Marty was a bit shaken up. And she said, Marty, I want to place an ad. Bob's died. And he's gone, oh, Mary, that's terrible. He's gone, look, you're paying $50 and you get 250 words. Bob's died is a pretty short obituary. You've been married to Bob for 60 years. Bob's 90. We all know Bob. Is there something you want to say about Bob as well? And so Mary's a bit silent there for a while. And this is what Marty was telling us. He didn't know whether to laugh, but it'd be quite sad. He waited there for a good 5 minutes on the phone, and he heard a crackle, and Mary came back to him and she said, yes. Bob has died, boat for sale. You see it fits into it. Look, I've got a slideshow. It's a very small one. I want to race through it, and I was going to apologise for racing through it too quickly. And I said, look, I'm going to do this in 10 minutes. But then I think with you guys, this might be a little bit slow. So I'll speed up. I'll speed up if I can. But before, I thought I'd start off with a bit of nursing blues, because you're saying you're seeing problems. And I feel really sceptical sometimes, and it's really important to frame problems as opportunities. And internationally, there's a whole lot. I just want to talk about the panel assessment, but it's the opportunities that present the challenges and the conundrums. And I wanted to spend a little bit of time today not bringing solutions, or certainly I'll talking about the blues, but it's really about those opportunities of unpicking some of them. But there's some real things that are hanging around and haunting us, I think, and slowing us down. When I said to Mary, what I want to do is really approach it as I would approach my clinical practice. I'm a mental health nurse practitioner. I mainly work with people with autism, work across the lifespan, but really child and adolescent mental health is my origins. And I'm on the board of editorial board for JCAP Engines, child and adolescent psychiatric nurse. It's sort of my passion. And I've been playing around with using and evaluating narrative therapy with kids with autism. And one of the things about narrative therapy is the mantra that just because problems are serious, you don't have to be serious about how you work with them. And there's some other things about externalization, which is untwirling some of the balls of string that present themselves and finding a way to concretely work through each of the issues that present themselves to find realistic solutions. So I just thought I'd start off with some nursing blues, even though I apologise for it being blues. So this is the nursing blues. I come here without any news. Hence I said I've got nothing to tell you. It's just a sense we've got to have another look. Can be pragmatic, we don't need another book. We keep using the advanced metaphor without clear idea of what for. The issue of time and volume and how exercise me in terms of the learning stuff. Mm-hmm. There has to be coherence between the three. When this is my second live show with the ukulele. In the first one I presented, I used a soprano ukulele, which was really cool. I was at the ICN conference, and it fitted nicely under the lectern, and I pulled it out ready to play, and I realised that when your hands are shaking, the frets are really small. So I had to get a bigger ukulele. So I want to consider a little bit about the language and the context of precision we use, but not only about how we talk about nurse practitionering or advanced nurse practitionering, but about being clarity of what's the work to do within our profile of nursing and who's going to do that work and how we're going to evaluate it. This is some of the things that exercise us in our work with standards. I led the team to develop the registered nurse standards for practice. Most recently, and before that, collaboratively with Tom Buckley, we led the team on the nurse practitioner standards for practice. And it was about balancing what's realistic to achieve matched to different volumes of learning, and where in a nurse practitioner as process from novice to developing expertise, we can expect that sort of thing. And I'll talk about it just a little bit in light with scenario-based modelling, and I will have a go at the word advanced because I get very stuck on advanced as a directional metaphor. Once we've done that, I was hoping to get the whiteboard and actually start thinking about some of the string of thinking that we've developed in terms of nurse practitionering and how we might pull some of those strands apart, particularly in terms of what to expect and when to expect the capabilities and the competencies to be able to show themselves, and match that to the volume of learning. And we've had a clear discussion as we've bounced around with the things we're going to put into the master's size box and how we're going to fit them is there. Before we start off, I sort of just wanted to do a bit of a Dr. Seuss, and usually I've played, but I'll just read this. The patient lay steaming, frustrated and screaming. All he'd asked was who's doing my care, and two nurses stood preening. I'm an APN, a nurse practitioner, said nurse one. I'm an APN too, announced nurse two. Now, 2 MPs thought the patient, this all makes sense, but then come the explanation, it was way too dense. I'm an MP, said nurse 1, and I'm a consultant, said nurse 2. You could put specialist here and on, because you know. The patient was so frustrated they began to turn blue. Please, said the patient, just do it now. What will you do? Just tell me how. Nurse 1 glared down, but it should all be clear. 2 things can be 1, and we are both here. I can order tests, prescribe and refer. Nurse 2 said I can't do those things. Consult. Specialist, perhaps, I prefer. Nurse 1 said, I can lead your episode of care, and Nurse 2 opened their mouth, but the patient was in despair. If we just talk scope, what can be done is clear. The patients will know that which is dear. Who will do what? The patient at last shouted. Nurse 1 and 2, their advancedness had flouted. I'm a registered nurse, at last, said Nurse 2. I'm an MP, said Nurse 1, so you should know what I do. The patient relaxed, as will planners of service too, when it is clear what worker will do the do. Unlike the Nietzsche's teachers of stars and beaches, it's important to know what is in each worker's reaches. We looked at this notion of advanced and all the titling that we're using in nursing. And the good thing about Ireland is you're really stuck to 3 titles: registered nurse, CNS and nurse practitioner. But I would bet, you know, a few pints of your best Guinness that you'll find the same thing. Is that the community of understanding of nursing hasn't kept pace anywhere with contemporary nursing. I have to apologise because I keep using nursing in Australia. We've split the disciplines. So midwifery, even though it's under the same book, is a separate discipline. And so, you know, some of the popular images I just pulled off the web without too much trouble of what nursing is. So the word advanced is just a foundational metaphor. It's a directional metaphor. And it really fits in with what we all want to do. As part of our Western philosophy of living is this constant notion of needing to progress, you know, to get a bigger car, a bigger house, more money, a better job. But it's really just talking about the flowing of reality and a movement forward. If people don't understand nursing, using the title advanced doesn't mean a lot. Because if we go back and look at some of these images, advancing from that's not going to tell someone I can wash a patient better, I can wash a patient without feeling too posh, I can, well, we won't even go into the rest of them. So nursing is responsible for articulating and disseminating clear definitions of the roles nurses engage in and the scope of practice. And that really gets down to being really clear about what's the work to be done. And it gets clear to our thinking when we start to line the 3 things up. What's the work to be done if we think of Anne-Marie's talking, and what are the priorities within that work to be done? At the moment, it's jumping up. That priority is really a clinical focus attribute. It's about setting up or participating in clinics and providing a full episode of care that allows to avoid hospital admission or to get out of hospital quicker to save finances, to intervene earlier to prevent chronic disease emergence. And so the primary KPIs, even though we talk about leadership, service design and research, the primary KPIs tend to be resting in the rhetoric of the discussion. It's not rhetoric, in the vision around that area. So when we talk about positions, what RNs are doing, what CNSs are doing, what nurse practitioners are doing, it's about being very clear about what we expect and want from those positions. And then that allows us to think about things like capability development. So we actually went around and we went to every state and territory and conducted focus groups with consumers to talk about what they understood of nursing, but also about person-centred care and how they saw themselves. And we found two really interesting things. One is separating below registered nurses, and other nursing positions was beyond every focus group. And in fact, nursing was just one blob. Now that's kind of scary when you think just over 2.5, nearly 3% of the Australian population are a nurse in some sort of form, and that is also matched in America. And so when you look at population sizes, that's huge volumes. Now, those nurses are assistants, they're registered nurses, they're a whole range of things thrown into one, and people aren't discriminating. When we talked about person-centred care, we found something really interesting is that people told us, look, we're really busy, we're really stressed, we've got to think about our mortgage, we've got to think about our children, we've got to think about what service we can get for our husband who's elderly and unwell. If we can think about one less thing, that's really important. We don't have to think about arranging our care. We don't have to think about this stuff because we've got a GP. We just have to ask a doctor, and a doctor will tell us who to see. And that's a very much pervasive thought in the Australian society, and I wouldn't be surprised if that translates internationally. And so when we're using concepts like person-centered care, it's thinking also about capabilities, how we position someone to be at the centre of care. And for nursing, one thing that we could really stretch our imagination is how we can get into school curriculum and teach people, as they do in Sweden and some other countries, health literacy and how to be at the centre of your care as part of your program. We know that with PhD PE in Australia that you don't actually learn to apply a condom or to prevent STDs until you're in year 10, year 16. Yet we know from the stats, horses bolted in many cases way before then. So there's something about teaching people to be at the centre of care. Often people say we'll do demonstrations, we'll do trials, and we'll build evidence, and that's really important in light of policy work, which is Anne-Marie's talking about. But in terms of whether that's going to change anything, actually the evidence suggests that it doesn't matter how much evidence you've got, it's not going to change your barriers to practice. So as a bit of an exercise to explore that, we sat down and we mapped, and it was a very quantitative approach, and it's not my only bias, but it does give you a very easy way to do it. So we matched RCTs and systematic reviews of nurse practitioner efficacy, safety and quality of care and cost effectiveness against barriers to practice. And lo and behold, the frequency of reporting of barriers to practice hasn't reduced despite the building of obvious evidence that nurse practitioners at master's level are as safe as their medical colleagues in the provision of care within the scopes that have been researched. And in fact, they're no more expensive. There's this myth in Australia that, well, what if they're more expensive? When we actually looked at the few economic analyses there, we found a few things, but one was this really interesting assumption, because economic analysis is based on assumptions. And the study that found nurse practitioners more expensive, of course, had the assumption that doctors were free, because you can't do without a doctor. So therefore, any service with a nurse practitioner was adding the value, the wages of the nurse practitioner. So nurse practitioners become more expensive. So there's no research that nurse practitioners are any more expensive. We know they're just as safe and they're quality. And we've got enough evidence around the world not to need to keep collecting it to persuade people to reduce these barriers. And so the barriers won't just go away with evidence. And one thing we've learned from experience is the support of medical colleagues won't come with evidence. It won't come with building good faith. It won't come because it's about protectionism, protection of power hierarchy and protection of financial security. And nurse practitioners threaten all of those elements. And so that was just an interesting thing to think about. It comes into scenario-based modelling, of course, and our health workforce, just as your health workforce, is using scenario-based modelling. Scenario-based modelling, of course, comes from scripting, straight out of Hollywood. That's where the whole thing emerged. And so in this script of healthcare, who can do what? Now, that's why it's very clear, why we have to be very clear about what work can be done with who under what circumstance and what capabilities, concrete capabilities, people bring at different levels of practice. So basically they form a script as the, Bob's sick, he fell off the bus, he broke his leg, he comes off the bus, who can do something? And then they add all that, well, these people could do this stuff. The scary thing, of course, is that the decision makers, the people who are doing this policy work, actually, from the research, don't have a whole lot of skills. They don't have the skills to read research. So that table I gave you isn't something they'd access and go, well, I'll go and look at all the RCTs on the effectiveness of nurses or midwives. They actually go back to what I said a few slides ago on their community understanding of who does what in healthcare. Yeah. This is what nurses do. So you'll get to watch the guy and you'll get to put the bandage on at the direction of the doctor. So that's getting clarity around what we're talking about and selling that message is really important at that really policy, sort of level. In Australia, when we got access to community stuff, and my head was racing off because I work in private practice, and so I'm not employed by a service, I'm not even employed by the university. When I got my chair at this university, part of my negotiation was I'd practice clinically, and that all was, yeah, come and do that. And then we hit a hitch with, well, how do we actually ensure an academic to do that? And so they asked me if I'd re-establish my private practice, because then it's clear, because then they can, I can rent the room if you like, and I have my own indemnity insurance and things, but I'm not employed by HSIE or a health service or whatever. And in fact, to have more of me, students should be able to come from that model as well, which means that they're not embedded, and I need to have clinical supervision, so I have to source it. Now I'm stingy, as you know, I don't like spending money. Maybe I've got some Scottish genes as well. So I have peer supervision. At different times I've had group peer supervision where other mental health nurses come, we go through cases and we do it collaboratively. At the moment I'm having individual peer supervision with another person, and we do the same. And so how I source it and how I can demonstrate it is on me, and I have to do it. But it's thinking about who provides what, and you know, it gets down to that sustainability. To be able to do that, we got access to the medical benefits system, which was a great coup. We had to have parliamentary roundtables. First, we formed a policy coalition. We went off. We had roundtables. Then we got a consensus agreement of something like 23 colleges of nursing and universities. We eventually changed the legislation with the will of the health minister. We then went through how we're going to implement it. We had all these working parties. At the end of the day, we'd got access, and I went off to the bureaucrats to work out. And one thing we hadn't paid attention to, of course, was the value, money value they assigned nurse practitioner service. Now, of course, think back to policymakers, their view of what nursing does. The driving idea was nurses could never be paid more than a junior doctor, so we'd have to give them no more than 2/3 of what a junior doctor would get for an hour of service. You're talking about, you know, residents who are doing rotations. And so along this bar graph, can you guess which one is the nurse practitioner's hourly compensation through the medical benefits scheme, which is actually the patient's reimbursement, so it's not where you get these out-of-pocket expenses bigger. Guess which one of those, when there's a mix of allied health, registered nurses, and nurse practitioners in there. While we're guessing, I'll just ask, has anyone online got any questions so far? No. Okay, so rushing through this so we can get to the juicy bit. Did you have one?
It always fun.
Yeah. Exactly. Yeah. And do you know what? These are registered nurses who actually get paid more under a different scheme. Now, this is a clinical psychologist. A clinical psychologist has a master's degree, and they're regulated by our board, and they have a very similar hour of practice, supervised practice requirements. And this is a nurse practitioner. This is purely based on that policymakers' decisions about the relative money value. And so when we talk about barriers and enablers, it's good to put extra candidates into the pipeline and hope that the pressure in the pipeline builds up and knocks the barriers away. But some of those barriers are way beyond nursing's control, and it gets back to some of that thinking of unwinding exactly what we mean by what works to be done by whom and when. So just to finish off with our patient. The patient said few. I know who is nurse 1 and nurse 2. What is more, the plan and you too. We all know what is done by nurse 1 and nurse 2, the two lovely nurses who certainly do the do. As well as scope, volume of learning must be clear, so we can all understand the nursing profession we hold dear. So you must be wondering about the so what of this reflection. I'll clear my throat and tune my inflection. It's the bare necessities of NP capabilities. It's how they hang together cohesively. Bird, let's go with feather. I mean the bare necessities of NP capabilities. We need the courses that bring the capabilities to life. But there's more. It's the bare necessities to develop NP capability. The label on the tin must clearly match what's within. I mean the bare necessities of NP capability. We need to get the education right to match the opportunity. Yeah. So for the next little while, because we did race through that very quickly, I want to have a little bit of a go at teasing through some of the ideas that we've had in the last two presentations. But these aren't just Irish ideas, they're international ideas. And in fact, to be quite, in the idea of full self-disclosure, my project for my sabbatical was actually to look at what a bespoke doctor of nursing practice would look like.
I thought you were going to say learn the ukulele.
That's right, already mastered. you know, I do have to disclose that was as much of the free tax department.
That was the long-term service leave. Go on.
Oh yeah, we're in the wrong one.
Well, actually, you know, after Scotland, we are going to Nashville, so there might be a slight improvement. Come back to a bit of a country western point. But my doctoral project is looking at nurse practitioner education and what a bespoke doctor of nursing practice might look like. And one of the things that, maybe should I do it on the whiteboard or the paper?
Paper if you can. Probably if there's a blank sheet there is, yeah.
It probably says permanent mark.
Okay, then
No, it's all right. So one of the things that drove my thinking, and it wasn't from here, but it is actually quite, it's just popped up that all the discussions here make it a bit of a contemporary issue. But one of the really concrete things in Australia is we talk about volumes of learning. And we talk about, for a graduate certificate, it's 4 units, if you like, of learning. And we use units because it's easy, but you know, you get the idea. Then we go a graduate diploma, which is 8 units. And we see that specialty practice is largely the graduate diploma. Some of the colleges say specialty practice is a grade cert, largely a graduate diploma. And it's credentialed by the colleges. It's not regulated by the board. The board made a decision not to be involved with specialist practice. And then we see at the top third, this is actually thirds in the bucket. So we've got 4, 4, 4. And this is a very typical model of a master's degree. And so by the time someone does their, graduate certificate, graduate diploma in specialty practice, the idea was that they carry on and do a Master of Nurse Practitioner. And in 4 units, so 4 subjects of learning, 4 modules as you call them, I think from talking to Mary earlier, something equated to 30 credit points in standard units. All of a sudden they would jump from one scope of practice, because this is all in the registered nurse scope of practice, and this is in the nurse practitioner scope of practice. And in making that jump, of course, the MP capabilities build on RN capabilities, but there are separate standards, separate sets of professional standards, and it's a separate accreditation by the board. And so you're jumping from one legislated scope of practice, regulated scope of practice, into another, all with 4 units of study. Now, having said that, the expectations of what nurse practitioners do as compared with specialist nurse, when you talk with service providers and a lot of discussion around, involves a whole lot of things like research, service redesign, policy analysis, and participation. And so there's all these things that would feel way beyond this small amount of volume. That gets compounded then when the general assumption is a bit like what if I just listen through my Australian years, what I would have heard with those 3 modules, plus clinical practicum would have been, or out of the 4, we'll have one on advanced anatomy and pathophysiology. We'll have one on diagnostic reasoning, to revisit that. Now we're going to move from, again, I'll keep jumping around. In Australia, we haven't decided yet. The recommendation has been potentially that prescribing be at a graduate certificate level using the same sort of model that you've got here. There's certainly got to be a volume of learning, and we're going to move to registered nurse prescribing hopefully in this year. But that's a collaborative prescriber, it's not an autonomous prescriber. So one of our modules would be still prescribing, because we're moving from a collaborative to an autonomous prescriber. So out of those 4 units here, we'd have 3 that would be prescribed at that sort of level, which would leave one unit of learning really to achieve all of this, if it hadn't already been achieved satisfactorily down here. So we talk about nurse practitioners, and we say, well, and we talk about registered nurses as well as being engaged in evidence-based practice. Now, to be engaged in evidence-based practice, just as an example, again, this is not one of my hobby horses, but to be engaged in evidence-based practice means I can read the evidence and make a decision based on that evidence whether I translate those findings into influencing my practice or not. Now, that means I've got a couple of literacies. One is I'm statistically literate, and the other is that I'm literate in assessing the rigor of qualitative research. Because if you present me a paper and it has statistical analysis in there, unless I can judge whether those statistics are correct, which means I know how to do statistics. I can only take the author's word for it. And you see so many papers where they'll do things like they'll say, okay, well, we haven't reached a statistical variance between our samples, but we still think this is a good idea. And we'll use words like almost or, and so how do I separate those things out? So when we think about, when I was talking to MREs, they're going to be provisioned to look from BN right through educational offerings. We have to ask questions. If we're going to try and do it all in one unit, that's not going to work. So where in here, in the foundation, is someone statistically literate? Where do they have the rigor to look at qualitative research? Where have they actually, below here, learnt about policy analysis and used things like the policy triangle, you know, Walton, Gibson, and others, and understand about policy windows and how they go about influencing someone to change policy. It's not just about having a good idea, it's about, you know, finding the opportunity and understanding all the other policy networks and nets that are involved to enable you to do it. So when we've got this small volume and the capabilities we often want from physicians leaks out over the top, and that was what inspired my thinking, well, what's the next bit of learning look like? Before, we'll make this interactive, before I sort of came here, I was wondering what's happening in America. 2015, they're all going to be GMP prepared. We haven't heard much since, and so I did a literature review and really had a look at what's happening in America and found that whilst this idea has a lot of merit, and in fact the number of DMP programs and the growth is astronomical. There's been a 10-fold growth since 2014 in DMP programs, only a 12% growth in PhD programs, and so there's going to be at least a 4-to-1 ratio of DMP to PhD graduates, at least, depending. So there's been an embracing of these ideas, but what's actually stopped it is that none of the regulators in any of the jurisdictions have moved to doctorate. So there's drivers and enablers, but there is this idea about this volume leaking over. It's really interesting then to also look at some of the conundrums they face. We can talk about that as we go on, but I'll keep talking for the whole hour, so I should open it up to anyone in the room want to say anything at the moment. Our cries of outrage are quite welcome.
I think
Jerry said great.
I've got an appointment at 3 o'clock. I'm so sorry, Andrews. There's an afternoon.
Do you have any questions before you go that you want?
No, I get it. I get it. Which is.
So,
are you saying?
Go ahead, Eileen, absolutely.
So Andrew, music, thank you. I prefer going with the title that Mary put on this, which is wonderful, advancing scholarship. I suppose it's, I hear what you're saying about the states, and I know what they said about the end. But from Australia's point of view, where have you moved with advanced practice and the doctorate and the scholarship in moving the advanced practitioners forward?
I think now I can't talk for Australia. I can tell you that.
For just your states.
Australia's fully national now, so we don't have any of those state.
So it's all the same.
It's fully national, and the nurse practitioner at the moment it's pegged at master's level. No one can authorise without having a master's. If you don't have a master's in nurse practitioner, there is a potential pathway you have to get a master's to go through and have that accredited, but really that's quite difficult. So looking, and that was really people who already had masters, looking forward, you have to have a master's in nurse practitioner. What we've wrestled with is a few things. One is that hours thing. And we came exactly to the same conclusion that Anne-Marie came, which is great because we've got that in the same way, which is the literature, is that there's no evidence related to hours prior to entering a nurse practitioner program and outcomes after it. In fact, the American Association of College of Nursing published exactly the same finding. There's no evidence about that number of hours within a program either. Now we've got to think, because we're consumers of evidence, is this because people haven't done the studies? Or is it something else? Well, it makes sense that there's no evidence for that entering a program, because you know, there can be the whole idea that 20 years can actually be 20 of the same experience over and over again. One of the things that comes into that, interestingly, is going to be this notion of portfolioing and evidence theory, how you manage that. But now, one of the conundrums in Australia is that we did have 5,000 hours of advanced practice before you entered the program, or actually the balance of completed program. There was a conundrum until the last lot of standards, and now there's a move to shift the definitions again. But we have this thing where you have to have, say, 5,000 hours of advanced practice before you enter the nurse practitioner program. The only way you can have advanced practice is to be accredited by the board post completion of the program. So no one could have it. So it's just a purely subjective thing. This whole conundrum of everyone wants to be advanced without qualifications necessarily go with it, I mean that that'll go back around again, and it'll be interesting to see what that clarity and advancements means. What we have gone to is 300 hours of supernumerary practice within the Masters and Nurse Practitioner, because we have a model very similar to what I'm doing here. And so people would say, okay, I'm joining up the course, my employer says that's a good idea, and Barb, the clinical nurse consultant, and Fred, the nurse practitioner, and Joe, the consultant, whatever, are going to be my supervisory team, and we're all going to agree on competent at the end, and the university would go, great, go off and do that. Oh, we've finished the program, is he competent? Yep, she's competent, she's competent. And we've realised that actually you need more work. And so we've got 300 hours of supernumerary. So it can be supernumerary within your employment arrangement if your employer is so minded, or it can be that you join other agencies. Now that has raised that question of insurance, and the insurance, of course, then isn't on whoever receives you, because they're not going to receive you. You can come to my hospital, I'm not going to insure you. So it comes back to the university has to do it. So that's raised those issues. So that's where we are. We did talk about whether you had a master's or a doctorate. We talked about it in print, my paper and a groups and another guys in the schemas. But what happened with our AQF framework, Australian Qualification Framework, is now there's only two sorts of doctorates in Australia. There's the hybrid or the professional doctorate, which is a mix of coursework and 2/3 research or a PhD. So all coursework doctorates got knocked back to masters. So physiotherapists, for instance, had a taught doctorate, and by whatever year it was, 2016, they could no longer teach it, and went back to a master's program. And so we can't have a taught doctorate of GMP, which was the sort of, there was momentum building because of this conundrum. If you've got all these aspirations for things like leadership, research, a whole range of things, you need more volume, you need a bigger boat. And the way to get a bigger boat is more units, and the DMP does that, but we can't do it. And so now we're stuck with, well, okay, if we're quite satisfied that you enter the nurse practitioner at the master's level, what would the doctorate opportunity at the other end look like that still consciously builds capabilities? So it's not just going off and doing some research, particularly because you really don't have the skills to do research. You're not entering a PhD because you haven't got a honours program and you haven't got a master's dissertation of enough length to go to a PhD. So it's not just about going and doing something, it's well, how do you build those capabilities? But all our Prof docs at the moment tend to, because they're very generic to get viability, tend to just teach research methods. Come and do research methods 1, 2, 3, and 4. And so we're wrestling now with, well, what would a nurse practitioner one look like? One way might be to prescribe what the research content is, which is something like critical action research or evidence-based and entry practice development. So at least we're not saying that become researchers, but they are capable in a focus area which might need service net. So there's lots of new things. So that's where Australia's at, which is sort of thinking. So yeah, so that's...
Sorry, Andrew, can I just clarify? Did you say then you are continuing the professional doctorate?
We've got two. We've got a professional doctorate, but not the DM. We're not got a taught doctorate, so we can't do a coursework doctorate. So a professional doctorate's a hybrid.
Does it have a taught component?
It does. Has a taught component and 2/3 research.
Oh.
So I believe you've got PhD and a hybrid or a professional doctorate, whereas America's got a taught doctorate, as you know, in which case you can do coursework, and then there's a graduate project, and there's a lot of discussion in literature, what should that be called? It's been, can't be called a dissertation, it can't be called a capstone any longer, so now it's called a doctoral project. But it's quite a small component. That's allowed them to do a whole lot of stuff in terms of this clinical as well, and how to integrate that as they move along. Which is interesting, one of the modules here that the board wants is clinical practicum, so it's interesting what that's going to mean here. So that's, but clinical practicum isn't a unit. It seems to be something at the moment in Australia that sort of goes along as a must satisfy requirements, as well as your taught content in a master's degree. But what's going to happen is, because more and more students are going to need facilitated clinical placement by the university to fund it, the only way to fund it is to stick it in subjects, which then makes the volume of learning smaller, because you have to have at least one subject called clinical practicum. So that's
why, that's one of the reasons our program here at UCD is so attractive, because we've had clinical practice in the very beginning, and they're competency based and they're integrated into clinical practice, so it's with our partner and with the mentor. But that's why our numbers have increased, because because I know, because the NMBI would say it. Other master's programs without a clinical practicum is what deters them from becoming the RAMPs, RAMPs.
So the only other thing we've got in Australia under the AQF, of course, is so that's the rules in terms of doctorates. The rules in terms of masters are straightforward. They're not very from this, except for AMAC, Australian Nursing Midwifery accrediting body actually does the accrediting courses. So it's separate to the board. It's a subcommittee of the board. It's a separate organisation. So that's a bit different. The other thing in the AQF is the rules about who gets to teach what, and this drives some of the faculty issues with nurse practitioners, is that you have to have a degree about which you teach. And we also prescribe nurse practitioners have to be involved with the teaching of nurse practitioner program. Now that means you have to have a doctorate to teach a nurse practitioner program, because nurse practitioner is a master's program at level 9, so you have to have level 10, which is a doctorate. To teach a bachelor's degree, you have to have level 9, because that's level 8. Same with a grad div. You can't teach a grad div unless you've got level above, which is one. So apart from that, I think our AQF has those rules, that the scenario is similar. That actually drives something similar to the United States, though, as faculty. As we know, there's no on faculty profile in Australia. We don't know, we know we've got an ageing faculty, but we don't know what the profile is in terms of qualification or age. But we do know we're going to be short of doctoral qualified nursing academics. And one of the drivers to rethink the DNP to allow nurse practitioners to grow towards having an ability to teach in these programs is up through. So that's a driver which is probably different here. Same driver as the US, but different to I'm assuming, do you have those sort of?
In relation to people who can go, so if you're saying people who teach, so that should have.
So you have to be the level above you teach. So to teach a master's, you have to have a doctorate.
No.
So that's another sort of slight difference. Did anyone online have anything?
No, I just got Justin to check if there was, just to remind them if they have any questions. So let's see.
Sorry, Andrew, just, the 300 hours, yours on the previous, have you built those into your modules? Or is it
pointing to these,
the previous slide, or the previous drawing? Yeah, the previous scribbles. Did you say you have to require, or is that going forward you have to require?
No, that's true. That was in the last lot of review of the accreditation standards.
And are they built into your module, did you say? Or I'm kind of confused as to where they sit, or what the credit load for that?
Well, these are interesting courses. I had the privilege of looking at a lot of masters because I was on the AMAC Nurse Practitioner Subcommittee. It's a little committee which we looked at the courses and accredited them. Up until this point, a lot of them, the clinical practicum is sat outside. So you have 12 units of learning and then must satisfy requirements for placement. It wasn't a unit of learning. No. But because it wasn't supernumerary, there wasn't any financial contribution of the university to that particular activity. And so the university didn't employ a clinical facilitator. They employed a course coordinator who looked across the program, but they didn't employ a clinical facilitator like you might in an undergraduate program. It was all done through partnerships where the placement was embedded. But now there's that 300 hours of supernumerary. You're stuck with, well, what if your employer says you can't have it? Well, you have to take leave. You have to go and get it. And so then you can't expect the receiving group, whether that be a primary care group or to then facilitate you, and you're mentoring, turning them back where you've gone. So the university will have to pay, like you would in an undergraduate program in Australia, but obviously not here because of where it comes, for clinical facilitators to go out with the student and to assess their learning and ensure the learning environment's optimally providing those opportunities. So now that there's going to be a cost, it will become a subject, because the only way for universities to get money in a lot of our funding frameworks, I'm sure yours is the same, is to have something to pin the money to, which is the subject. So that means it will drive it back, which means the volume of learning gets effectively smaller, because one of your units of study becomes clinical practicum, which was there next to it.
However, you could argue clinical learning is crucially important. So,
yeah,
you know, the theoretical instruction, you know, I mean, there's a balance there, because the clinical is obviously really important, while other courses of study might be shrunk. You know, I don't know, I'm just throwing it out.
If you're thinking of a full volume issue and you've got 4 units and you've knocked off 3 with that, you've got all these great capabilities to develop over here. Now, in nursing, we say certainly there's definitely value, but you go and talk to the university bean counter, who might also agree, but they won't have a mechanism to pay the school money for this person. And so you find that as sort of barriers and enablers that we're left feeling.
So the fees will go up for your student population?
Potentially, and then of course there's the drivers and keeping fees down.
And that's the, yeah, because I mean, we would pay for clinical would be a major conundrum.
Yeah, but it's there. I mean, it just hasn't happened because of the goodwill of the partners, really.
Yeah, absolutely.
It's all the other thing about that model, though, that strikes me, and this was a question I asked Anne-Marie, is that that's quite like ours, Andrew. You know, RGN, Practicum, and Masters. But if you can access and become an ANP, you don't necessarily need to do the graduate diploma.
Okay, thanks. But the interesting, and us hearing that too, and it's very, because I was thinking, can you then say that this is on top of the graduate?
Well,
now, we've gone through different phases. Some of the courses are, and they're actually quite long. And what I was hearing Anne-Marie was a real opportunity to be able to say that, because it's a different scope, a different sort of practice you're developing.
Yeah.
Which gives you a better volume if you can do that. But what we'll find in Australia usually is that either you get credit for prior learning for a portion of this. It might knock off a third and not the full amount, because you can't credit off too much. All the units are actually embedded in, and you get, for viability, IKEA type programs where you get multiple masters running and they share these units. So this unit can be used in your schedule for your nurse practitioner program as one of your level 9 or level 8 units. Or alternatively, if you're not doing this, you might be in the same class, but you're doing this as part of your grade deepening. And so you get those IKEA models of building viability of units, which is the sort of financial realities universities find themselves. You know, it's just you've sort of got 17 programs, 16 operating, and you know, students can choose whichever one, and so you have to make sure you've got whatever you, I heard you say about 6, is it? You've got to have 6 before a course of 1 or 8 or something.
Yeah.
So you get ways that people meet the viability numbers.
It shows the, you know, we come from a model where it's advanced practice has been developed with the specialty, as in the people are working in these specialist services, and Marie's new idea is very much forming on the actual, you know, unscheduled care. So I agree, we may not need, or the person may not need, not the specialist. But I'm just, it's over 2 decades now since I worked in Australia, Perth and Sydney, but attrition rate, not just due to retirement, I'm not talking about those people, but I mean, you know, one of our things at the moment we're losing are really good RAPs, RNPs, and I sometimes think it's because maybe just their service area or their service delivery doesn't, maybe, you know, after 5-10 years of doing it, maybe there's nothing there. I don't know, and I'm not too sure, I haven't investigated this enough, but I know we're losing really good people, and not huge numbers, we don't have huge numbers, but there are people leaving it. I'm mainly going for monetary reasons, going to the Middle East and places to work. You know, so I understand the tax-free bit and all that, very attractive. But what have you done in Australia or have you done anything to look at nutrition and how you keep people? And is the doctorate and is research the part that's missing for some of these people?
Now the answer to that is I'm not aware of the research that anyone's looked at that.
We're smart enough for me to know. That's the problem.
What we have determined is that when you become a nurse practitioner, you become a novice nurse practitioner, which to a lot of nurse practitioners was sacrilege the first time we started to talk about it as we're developing standards. But just like you enter the scope of a registered nurse, you enter as a novice and you build expertise. So the question then comes up is how do you consciously build your expertise to fully utilise the scope of practice as a nurse practitioner? And when you look at the standards that you've got now, and some of those standards were quite lofty, that to really fill those standards, you've got to be really a policy analysis, because it actually explicitly says that you're going to influence policy and be part of that. You have to actually be able to do research. Which is a big claim for any course of masters. I mean, we've got PhDs, which the learning outcome of a PhD is to become an expert researcher. And so it's a stretch to say that at the end of a taught master's program. So really, a lot of those capabilities in your standards are aspirational at the bottom of a master's degree. So then the question is, how do you move from a novice to fully utilise that scope? So how can you actually fully demonstrate, I can do all these things? Well, there has to be extra learning. There has to be clinical experience that's supervised, but also formal learning, because that's always part of the project. Whether that formal learning is through a formal project, program like a doctorate, or through other, pieces of learning, that's really the thinking where people are at the moment. The easiest way is through a doctorate. And that way you can actually move from being a novice. One thing that will restrict it, of course, is the pay scale also needs. In Australia, there's only 2 steps. There's first and second year, and then it's flat forever. We need to actually think about those hierarchies. And in America, from the literature, I've not asked anyone about these things. It'd be interesting when we go over, but from the literature, when I was at Southern, I went to Cal State University and did a days teaching and doctoring, but did talk to some students, and there is, because they're less on award wages, and so there's more individual negotiation between services, and so there was wide variance in the class between what these, because these were in their last year and we're about to graduate, and one girl had a job in the ED which was going to get her somewhere around 120, but someone else in primary care was getting like 68,000 US as their first year. What the literature is sort of saying is, though it hasn't been evaluated, but there does appear to be a trend that if you're doctorally educated, you do get better remuneration. So that's an issue we're going to have to face. Is there's no financial incentive to move beyond novice, but at the same time, unless people start being these nurse leaders, which is hoped for, you'll have ministers turn around in 5 years' time going, well, sure, they're running these clinics, and sure, there's less hospital days, etc., but where's all the innovation? Where's all the... And then it gets back to the nurse practitioner and the universities, you've failed. So getting this thinking right is the thing. But there has to be a pathway from novice up.
Yeah. I think our possibly our problem is cultural in relation to that movement. I think, I think there's an element of thinking within the advanced practitioner cohort. They're not at the decision-making table. They're kind of still the clinical arm. They're not in with the big wigs, and they're out on a loop. And I think culturally they perhaps don't feel as supported as they should, or motivated or encouraged to move forward with a doctorate, or to get involved, or it's just so busy. And maybe we've come from the moratorium now. Obviously we've come through a bad time. Maybe things will improve, but I think culturally it has been difficult.
It's interesting, isn't it? Unwinding some of this is the opportunity.
Yeah.
Particularly when there's this policy window that's open and there's all this momentum from the department. Because are they at the policy table? Are they sitting down with the service planners and directors of nursing? And well, actually, in this, we've not equipped them. And so maybe that's where the doctoral person sits down, but then what's the remuneration? If I'm going to develop myself, am I going to get actually part of this package of money? Is it going to be to move this whole system forward? Because
the picture in my head I get, and we talk about Australia's 2%, and not necessarily yours, but it's a bit like a very bad tap. And we've got blockages like in-service attitudes of where this fits. What do the directors of nursing think? What do the current nurse leaders think? Or are they going to defend their patch? How is all this going to fit together? But if there's 140 already unemployed, there's blockages in the system, and that's what that research about barriers, not responding to evidence is. Building the pressure up will unblock some of it by dropping in 700, but at the same time, there has to be a real discussion within the knowledgeable community of nursing, ask those questions, have all the directors of nursing together and say, well, these people are expected to do this. How does this happen? Where is the place at the table? How does it happen in your organisation, and how do they feed up into it? Or is it just going to be a disruptive innovation that's going to cause all sorts of stress?
Well, it's an interesting one. I think it's probably going to be a disruptive one, assisted by a policy, and I suppose that's probably depicted by, we've waited for a long time for this. I mean, we've been talking about this for as long as the program's been running because people have been abroad and seen what's gone on in the States, etc. So I don't think the directors of nursing, I think we're very fortunate in many ways by the people we have in senior positions, and that they're young, motivated, and they're an essential part to our academic community. Many of them have a PhD, as we see with the people this morning. I suppose when I'm listening to you there, Andrew, I'm thinking about, how do we go about this change? I mean, one of the things that strikes me is that this disrupts all of our programs that are on that pathway, because currently we have, dare I say, a need pathway. You do a graduate diploma and a specialist, and you move on to a master's, and preferably if you want to do an advanced practice, you do bespoke advanced practice program. And opening up that graduate diploma where, it's no longer a requirement to have the specialist, I suppose there's a real risk, and I suppose something we need to be careful of, that we don't throw the baby out with the bathwater, because one of the hallmarks of our graduate diploma is our clinical specialists are very clinically skilled nurses.
I personally, I think, Mary, there is an element of the bedrock of learning still being necessary in relation to medical or surgical or different specialties. Now maybe I'm, and I don't think I'm traditional about thinking about that, but we could revert a model similar to the critical care masters, where you have the specialist, and the second year is the advanced practice year. You could reframe. But I think we can. And I don't know. Would you agree with me? I think the specialist, for many of our CNSs and our specialist nurses and our knowledgeable people in practice, that's the bedrock of learning. Unless they shift it back into the undergraduate, I don't know.
I find it hard to understand where you could get, say, an A&P in 2 years, saying diabetes, without having to do the grad cert in diabetes. I know that's exactly what I'm thinking. Like, there are lots of specialities that have grad certs. That is the foundation to do your advanced practice.
But we will no longer have an advanced practitioner in diabetes. It would be an advanced practitioner in chronic health.
One of the tricks we've got there too, using advanced metaphor, is the idea that there's progress in a direction. But one of the things we found with nurse practitioners in the research underpinning the standards is they don't become more specialised. A diabetes educator doesn't become a better diabetes educator. They go back and develop a firmer base on which. So I use the example all the time, like in mental health, all of a sudden I had to rediscover livers and kidneys, which I didn't have to care about. But when I start prescribing, I care a lot about them. You actually get a much firmer base. That service knowledge of where to refer, I had to actually really understand the primary care networks and the funding mechanisms, whereas I didn't have to when I was in the specialist mental health field. And so that idea of advancing is not quite right, because you then retreat back to a more generalist. The real risk, and we discuss a specialist generalist, and I think, because you're still developing specialty knowledge, but in primary care, which is a different sort of idea. I don't know, but I mean, that's an important idea, is that you don't keep specialising, is that you develop a much more general base. And that's where those modules are around, because as a diabetes educator, you do a lot of collaborative prescribing, but you're not autonomous prescribing. You can, perhaps recommend, I don't know here, that in Australia you can't order a whole lot of investigations, whereas in a nurse practitioner you can order whatever you like. And so you're not becoming better at it, you're fitting what you can do within a bigger frame. So all of a sudden there's a scream of the brakes, and that's where our programs fall down in this modular idea, because the modular idea is you build and you build and you build, you become a nurse prescriber and you do your grad dip and then you become an advanced, where it's actually quite different. It's that you build to a level and then you broaden and generalise.
But because the CMS has been separate, we had the National Council a few years ago and they were expanded. And in some ways now you can see, in many ways, our students who do our bachelor's student and then going on to do a master's is really, because nobody's apart from the employers, nobody's minding the clinical nurse, clinical midwife, specialists, only minding it, but nobody, it's not a registration, as you said as well. So, and we have said for quite a while, really the master's now is the new level for many of our graduates. So it is, Mary, it's and maybe,
Well, I can assure you it will be a massive sea change within NMBI, because quite recently, to my horror, they still require, Mary's gone now, I should have asked Mary about this, education in the specific area of practice. And a point I have about this, I know a nurse practicing in venous thrombus, whatever, VTE or something, James is within the specialty of vascular medicine. A nurse of many years experience in cardiovascular, a master's degree, master's educated, CCU ward manager for years, la-di-da-di-da. She couldn't get on the CNS register because she didn't have a specific module in vascular, as if the vessels in the legs weren't linked to the heart.
Can I ask you a question?
And that, honestly, so that is alive now. So sorry, in relation to specialist knowledge. So
we'll take the specialist though, because you said masters is a master's is the new grad dip, isn't it? Because if you have a unit grade,
part one, I agree.
Yes, first year, yeah.
But even if we don't think modular, if you had an 8-unit grad dip to become if one to be what we're talking about, a specialist.
Venous
vascular medicine or vascular.
So to do this, and if we took nurse prescribing away and we went back 5 years or whatever it was, I would have still got a grad dip, wouldn't I, which was 8 units. But now I'm going to have nurse prescribing, which is 4 units. I'm going to be a vascular specialist in 8 units. Well, 4 plus 8 equals 12, which is your master's gone.
Yes, our nurse prescribes at level 8, so okay, we've done something different.
No, a grad cert plus a diploma equals master. So 4 units, we'll just say units. So you could say 4 modules of subjects. Okay. It's going to be a grad cert for one. Your prescriber is going to take up that many credit points. And then you still got to put your specialist on top, because he's not teaching the same stuff. And so that's made that space. Well, in Australia, that would be a master's. 4 plus 8 equals 12, but I don't know.
Exciting times ahead as well.
We have lots of challenges ahead. Lots of challenges.
Okay, on that note, we're going to close. Thank you, everyone. Thank you, Arlene and Rita, and Corinne, and Lucia, and Andrew. And we will make this available so people can have a copy of it.